Good morning, everybody. This is the public board meeting of the North East and North Cumbria Integrated Care Board, 26th of November 2024. I'm Liam Donaldson, the chair of the board. I'd like to welcome everybody this morning, including those who may be listening and watching online. We have apologies for absence. Kelly Angus, Interim Chief People Officer, has apologised. Claire Riley, Chief Corporate Services Officer, and she's being represented this morning by Dan Jackson, Director of Policy Involvement and Stakeholder Affairs. And on some of the items that Claire would have spoken on, Deb Cornell, our Board Secretary, is going to speak on them. And also apologies from two of our partner members, Ken Bremner, Foundation Trust Partner Member, and John Pearce, Local Authority Partner Members. Declarations of interest. Members have already submitted their declarations and they're all available in the public domain. Just to highlight one item that's coming up later on, agenda item 15. For that item, John Rush has a conflict being a trustee for Cumbria County Council for Voluntary Service, and Lisa Taylor is employed by Vaughan and the lead for the partnership programme. So just to note those conflicts of interest, but those members will be participating in the discussion. And then if I could ask our board secretary if we're quorate. We are, so thank you. We'll proceed. And then are there any points of accuracy on the previous board meeting held on the 1st of October 2024. So we take those as a true record. Are there any matters arising that anyone wants to raise or the points that are noted in the action log? Thank you. So that brings us on to, and I would just ask you to highlight any items of other business that you might want to raise so that we can add them to the agenda. Are there any? No? Okay, thank you. So we now move on to the Chief Executive's report, and Sam Allen, our Chief Executive, is going to give that report.
Thank you very much, Sir Liam, and good morning, everybody. So my report's quite detailed this month. I've got quite a lot to go through, but I want to start just by sharing the event that the Secretary of State recently attended in Middlesbrough, which is the very first of several regional events he's holding across England as the Secretary of State and the Chief Executive of the NHS, Amanda Pritchard, consult with the public on what's called NHS Change. And this really is how to tackle the three key shifts that the Secretary of State has set out to the public that the NHS needs to make. So from sickness to prevention, hospital to treatment, and also analogue to digital. And I was really pleased to be able to spend the day with the Secretary of State listening to the members of the public who had convened, he had convened from across Yorkshire and the North East. And I was really quite struck by the conversation at the event from the public. So it was really evident that the public still wholeheartedly support the NHS, deeply committed to an NHS free at the point of delivery. I think it's also evident, as we've certainly heard both through national surveys that are undertaken and indeed more local feedback, that this view that the NHS, in order to be sustainable, we also, particularly around the shift from sickness to prevention, need to really look at how we can support people to stay well, to maintain their wellness and their independence as long as they can, to have less reliance on hospital-based services and more support around them in their communities, in their neighbourhoods. And indeed, I think we'll hear a lot more over the forthcoming months about what's being called a neighbourhood model of care, which essentially is everything that includes your general practice, your pharmacy, your optometrist, but also the community and voluntary sector organisations, schools have a big part to play, particularly around education, supporting members of the public. So how we can really look at bringing together services, not just NHS services, but all services around an individual's needs. And we're expecting the new NHS 10-year plan to be published around May next year. And for us in the North East, North Cumbria, we'll obviously use that as an opportunity to review our integrated care strategy, Better Health and Wellbeing for All, which already sets out our 4 key strategic goals. But it'll be a good opportunity for us to take stock and think about anything we need to do differently. Just in terms of those 3 key shifts, just today, in fact, the government is announcing a new white paper titled Getting Britain Working Together Again. And I'm really pleased that we here in the North East, North Cumbria, will be one of 3 health and growth accelerator sites. And what that really means is that we're going to be given additional funding, about £18 million worth of funding, to support people who are off sick, in ill health, perhaps unable to work due to waiting for an elective procedure, planned care, an operation, to really support people to both maintain their employment, which is really important, particularly around growing the economy, but also tackling ill health. We know that there is a strong evidence base around work and people's health. We know that particularly for people with both mental health and also physical health conditions, having meaningful employment, but also employment that is appropriately supported through a good living wage, can have a really significant impact on people's overall wellness. So that whole focus around sickness to prevention, for me, that really brings to light that this is a sort of an endeavour for the whole nation, not just the National Health Service. This is something that we've really got to work together with all of our partners on, and I'm really pleased that we've worked very closely with our combined authorities on this bid, because again, work and health isn't something that the NHS can do on our own, and in fact our combined authorities, local authorities, have an even bigger role when it comes to this. So working jointly together with them to look at how we can tackle ill health, support people to remain in work, but also where they can, through interventions to support their health and well-being, get back to work, is absolutely where we want to be. And I think when we think about those 3 shifts and the NHS plan, the role of integrated care boards and integrated care systems is really important, because of course the population health needs in the North East and North Cumbria are quite different to how they look in Surrey or Berkshire or over in the West Country. So we've got to take the national ambition, if you like, and I think we've got to set what our priorities are here for our population. It then leads me on to think about the finances, and obviously since our last board meeting we've had the Chancellor's budget, which did allocate an additional £22 billion for the NHS, which we're incredibly grateful for, both in terms of revenue and budget. The board will be aware that we've also had settlements on a number of pay deals, which also need to be resourced, and therefore, in spite of the additional funding, we do know that the 25-26 financial planning year is going to be another incredibly tight year for us. We will come on to talk about the financial report, but I am pleased that so far this year we are delivering against our plan, and we are still forecasting to deliver our break-even plan. Every action we take now to get ourselves in the best possible position for the year ahead is going to be really critical, and indeed next year, hopefully, will be the final year of a single year financial settlement for the health service. And beyond that, we'll move hopefully to at least a 3-year settlement, which I think will enable us to certainly take a more medium-term view on planning how we use the health resources we have available. It would be remiss of me not to mention the changes to national insurance that fortunately aren't impacting the health service but are impacting business and indeed our community and voluntary sector partners. We spend about £50 million a year with the community and voluntary sector here in the North East, North Cumbria, and for those providers that are delivering services with a large number of staff, the 20% increase on national insurance will obviously be a cost to be borne, and that will not be a cost we are getting in addition to our current allocation, and therefore we will have to work with all of our suppliers, our providers who are having to meet that additional national insurance cost. And we know already from talking to some partners that is going to have quite a significant impact, whether they're a hospice or a community and voluntary sector partner, and indeed our care homes, residential homes, particularly given our responsibilities around continuing healthcare services. So that will be something we'll have to work through, how we can mitigate the risk of that. We are indeed already starting to explore how we could put together perhaps packages of support which may not involve funding but may involve things like good access to advice for business planning, efficiency planning, etc., given that additional cost that will be borne by a number of our providers we already contract with. We are waiting the planning guidance for 2025-26 in true NHS style. That has a habit of arriving just before Christmas, with the exception of this year, which was much later. So I'm hoping that we do get the planning guidance as soon as possible, because indeed it will be once we get that guidance that we'll be able to get on with concluding our planning. I do just want to assure the board that we're not waiting for the guidance. We are getting on and doing what we can, but indeed the guidance is important for framing how we conclude the plan for 25-26. Chair, my report does go into some detail on the huge amount of work that our urgent emergency care network has undertaken around winter planning. Whilst we have seen a slight dip in the temperatures, I can report that we are starting to really see pressure on our services increase. It was an incredibly busy day across our services yesterday with demand A&E, and we continue to work with our partners around doing all the things we can proactively to mitigate that risk, which do involve keeping people at home where we can and giving them good access to a more community response service. It also involves doing all we can to signpost people to the most appropriate service the first time, and obviously doing what we can to reduce the demand at the front door of our emergency departments. I am really delighted, it's not in my report, Chair, you'll know that in our first year as an ICB we secured resources for a new urgent treatment centre in Middlesbrough. Delighted in the last week we've secured capital for a new urgent treatment centre over in Carlisle as well, and that will continue to see the expansion of our urgent treatment centres, and we've got a process underway in Newcastle at the moment where we're looking at a new model of urgent and emergency care as well. So our developments continue across the region, and I think really using this opportunity where the Secretary of State's consulting with the public on a future of the NHS, I think, and indeed we'll be talking today around some of our public involvement work around what we can do more locally around supporting people to understand how to access and navigate NHS services is something we want to do. There's just three final things I just want to touch on, Chair, if I may. First one, a term that I think we'll hear a lot more of, public sector reform. What does that mean? We're obviously operating in constrained financial times. The Chancellor has been very clear about that in her budget announcements, and therefore all public sector services, not just health, it's incumbent upon us to look at how we can arrange our services so they're as efficient and effective as possible. And this is a key agenda of our local authority and combined authority partners as well. So how do we sort of really transform the public sector services? Indeed, the white paper I referenced earlier around getting Britain working again, around how we really look at better support around job centres, a better deal for younger people. How do we make it much easier for people to navigate services? How do we share our buildings? How do we stop putting people through repeated assessments? How, indeed, do we look at even how we look at our other infrastructure, whether it's digital infrastructure as well? How do we look to share this and therefore reduce the burden on the taxpayer to services, but also making public sector services sustainable into the future, because it's already clear we can't continue, and the Chancellor's been very clear on this, continuing to put more and more money into public sector services. So we will be working really closely with our combined authorities, with the North East Combined Authority. You'll see in my report we've already scoped out how we're co-producing this work together, and we can expect, I think, more work on that. The second thing I just want to touch on is today the Department of Health and Social Care have launched a consultation on the regulation of managers in the NHS, and the board will be aware that I've taken on a responsibility as the National Director for Management and Leadership. I've been quite vocal over a number of years on the need for the regulation of managers. It's something that I believe is overdue and much needed. And you'll see in the consultation, the scope of the consultation is one of the key questions they're asking is actually who should this apply to? And I would, Chair, and perhaps you could do this on behalf of the board, seeking the views of the board. We could submit views from the ICB on this in terms of where regulation should be applied to. I can understand that there will be concerns, particularly around dual professional bodies. A number of managers are also clinicians. They're also regulated by their own professional bodies. So there will be some aspects of this which will need to be thought through, and I'm sure that we can submit our views on that. And I would encourage all colleagues across the service locally to get engaged in that. And then just finally, Chair, at our last board meeting, we were joined by Baroness Hilary Armstrong, who chaired the North East Child Poverty Commission. And the board will recall that one of the recommendations in that report is for organisations to adopt and implement the real living wage. Just to say that from an ICB perspective, we have been looking into that. We will be taking a paper through our Finance and Performance Committee and indeed our Remuneration Committee with our pay policy, and it will be our recommendation that we adopt the real living wage in the ICB, and we're also furthering discussions with all of the 11 NHS trusts in our region. A small number have already adopted, and some have been doing this for some time, the real living wage. Not all have, but we'll be working with our NHS trusts to hopefully secure sign-up from the whole of the NHS across the North East, North Cumbria to that recommendation. Thank you.
Thank you, Sam. Any comments and questions on Sam's report? John Rush.
Just a quick one, Sam, and you alluded to it at the very beginning of your presentation about the £18 million that's available. Just a few questions so I can understand it a little bit more. Who is, or which organisation or committees or structures is that going through in terms of allocation? That's the first one. Secondly, how long is the £18 million? Is it over 1 year, 2 years, 3 years, 4 years? So I can get an understanding. And then thirdly and fourthly, sort of two connections really. One is in terms of returning to work, one thing I found with the VCSE sector, supporting individuals who are off work and struggling and whatever from a mental health perspective and helping them out with applications, all that sort of thing. Got a really good track record in doing that kind of thing. So that was what I want to say. And also as well, just in relation to overall health and well-being and support for people, the links to the leisure industry as well, which I don't know whether we explore as much as we should or could do within that across our area. And then on the final point is, does that cover the whole of our ICB or is it just the North East? Sorry.
Yeah, thank you, John. And I'll ask Dan and perhaps Neil as well to come in and say a few words, but just briefly from me first. It's our Healthier and Fairer programme board that will oversee this. It is for the whole of the North East and North Cumbria, not any one part of it. And it will also build on some already successful pieces of work that a number of partners are involved in, including the community and voluntary sector. But Dan, I wondered whether you wanted to add to that.
Yes, our understanding is that although this funding will be received to deliver a new models of intervention in 25-26, this will be mainstreamed activity for ICBs to oversee in the subsequent years to follow. However, it's not clear yet exactly what that funding package will look like, but they're wanting ourselves plus West Yorkshire and South Yorkshire as the three ICBs who've been chosen as Health and Growth Accelerator areas to develop the service model really that will then be hopefully rolled out across the country. And as Sam says, we're building on both our Waiting Well programme, which has a really strong track record in terms of identifying patients who are in most need of additional support, alongside the Patient Advisory Service, which we trialled with our DWP colleagues in Durham and Tees Valley. So the model is still very much emerging, and it'll be delivered alongside some important work that the combined authorities are leading as well around what's called Connect to Work supported employment programmes in both our combined authorities and in North Cumbria as well. So we need to make sure that we've got that join up as a system.
Whether Neil wanted to add anything on?
No, I think Dan's covered it. Just really, we're going to use some existing work to roll this out. We're not starting from
Thank you. So, Sir Pally Hungin.
Actually, I put my hand down, but my question was precisely that. Do we have any pilot schemes, or are we aware of areas or locations where something like this has been tried with some degree of success? And I just wondered whether, it's a rather cynical question, forgive me, whether the returns are going to be worth the effort and money going in.
Yes, there's some examples around the country of combined authorities leading this work in partnership with the NHS, particularly in Greater Manchester, which we've looked at. But as Neil said, we wanted to, our concept that we put forward to the national team is very much based on building on our two existing programmes that we think we could connect pretty effectively in this space. And as Sam mentioned before, we know the health and well-being impacts of both accessing employment and staying in employment as well. So it'll very much have a sort of more of an early intervention focus, our programme of work, in helping people to sustain work and access work in the first place.
There was one point I wanted to raise, and I'll direct the question to our Chief Digital and Infrastructure Officer, Graham Evans. These three shifts that Sam mentioned that are the government's strategic intentions, which are really important, the treatment to prevention, hospital to community, and analogue to digital. And I think people feel that the whole sustainability of our health service, our model of tax-funded service provision, equal access to all, the sustainability of that depends on these things being successfully achieved. But having been involved in some discussions about them, I just wanted to highlight the digital one, because the goal, quite rightly, is analogue to digital. But in reality, you could probably say that that journey is fully underway. But what seems to me the crucial point in the shift is digital that would meet people's expectations of what they can do in a modern world. And in that respect, my impression is the NHS falls behind. Lord Darcy mentioned doctors spending half an hour to log on to the systems that they need to use. Other doctors have told me that that they have to log on to separate systems to get different pools of data about their patients, diagnostic test results, things of that sort. And obviously, from the point of view of the patients and the public, being able to get access quickly, to be able to get information, to be able to talk to somebody, all of those things people are able to do in many other fields of their private lives, but not currently in the NHS. So that seems to me, whilst the analog to digital is quite a small step, the digital to the standard of modern life, which is moving very quickly all the time, is a much bigger step. So, Graham, what's your assessment about how far the NHS has got to go on that?
Thanks, Sir Liam. So I think we've made a lot of progress, but fundamentally, I think some of the basics aren't there yet. So within our digital data and technology strategy, we have 5 key themes. The first of which is getting the basics right. We have a lot of tech, but as you say, if clinicians, for example, can't access Wi-Fi, if they've got multiple logins, it creates frustration. Many other sectors have used the consumer as part of their value chain, and that pretty much supports the shift left notion. So if you look at banking, we're not building too many high street banks anymore. We've got the consumers of banking services using apps, for example. We also recognise that not everybody can, will or wants to interact digitally, so we want to build inclusion as part of our strategic direction, but provide alternatives where our patients, members of the public, can't access digital. Within hospitals themselves, we've had a lot of movement over recent years to create electronic patient records, EPRs. However, moving away from what we would classify as disparate systems that are connected together. So we are making the shift. It's not far enough yet. The big challenge is we do need to put some investment in there. And for me, the biggest transformational benefit will be when the workforce changes. So, when I worked in industry, when I digitised chemical process, the workforce size and shape that we started with was very different from the workforce size and shape that we ended with, because fundamentally we need to do things differently. I don't think we've made that transition yet within healthcare. I think we're moving towards that, but there's still a fair way to go. My key question is we need to get the infrastructure right, the basics, then start to build the transformational services on top of that.
Thank you, Chad. Can I just go back to the point that Sir Pally made briefly, just in terms of the resources and the outcomes? So the Treasury has supported this, and they've supported it based on really detailed kind of modelling on the numbers that we're facing at the moment, and particularly around that sort of balance between people receiving benefits and being out of work, so not making a contribution to the economy. So we know that 4 million people nationally are not economically active, and 2.8 million out of those have got a long-term condition and or a sickness. And so when the Office for Budget Responsibilities looked at the sort of medium to longer term forecast, doing nothing isn't an option. And so the plans we've put together to secure the resources, it is a plan, we've got to enact it, and I think we will definitely learn some things along the way. I think we've got some good evidence that we can build on, and we've committed to deliver some and secure some outcomes. Whether or not this will be wholly successful, I think the proof will be in the pudding on this one to some extent, but there is an evidence base around it, and it's had the Treasury backing to support it.
Thank you. And then just one thing to raise with our Chief Medical Officer, Neil O'Brien. There's been a lot of public concern, as you know, about the physician associate role, and the Secretary of State's recently organised for a review to be carried out. What are the issues that you think need to be resolved if this model of care is to be continued with?
I think one of the main, I think the scope of practice and also how physicians associate kind of weave into the medical workforce. In our area, mainly physicians associates are in the hospital sector. There are a few out in primary care. But the big discussion appears to be around how they are regulated and how we ensure that the education and training is kept up to date for physicians associates. And there are active discussions at a national level on that. Of course, we need to remember they're a workforce here as well, and they need some support as well and direction. So I think it's how they fit into the medical workforce model, along with consultants and training grade doctors, that I think needs to be worked through. And what distinguishes them from some of the extended roles that nurses have within the health service as well. So I think there's a lot of a debate still to be had, you know, we certainly support those discussions locally.
Thank you. Are there any other points on the Chief Executive's report that anyone wants to raise? If not, we'll move on to the next item. We now got a run of governance and assurance matters, the first of which is item 9, which is the Board Assurance Framework for Q3 of 2024-25. And Deb Cornell, our Board Secretary, is going to present that item.
Thank you, Chair. So the report provides the Board with the latest version of the Board Assurance Framework, along with the Risk Management Report as well for Q2 of 24-25. The report is the usual format to the Board and includes the updated Board Assurance Framework at Appendix 1, which the changes throughout are noted to help for ease of reference to note what has been changed since the previous update. The also included is the latest version of the Strategic Risk Register at Appendix 2 for information and to provide a bit more detail behind the assurance framework itself. The covering paper does highlight the changes in the risk movements throughout the period, and obviously detailed on pages 5 and 6 of the report. Both the framework and the risk register have been through all of the relevant committees prior to coming to the Board, and it was recommended for a submission today to the Board. So the Board is asked to receive the framework and the Strategic Risk Register for assurance, and happy to take any questions, Chair.
Are there any questions or comments on this? No? Are you happy to receive it then? We're also asked, I think, to review the Corporate Risk Register for assurance.
And just to know that is done by the committees as well, so that has been done as part of the preparations.
All right then, with your approval, we move on to item 10, which again, Deb is going to present. This is the Complaints Annual Report for 2023-24. Now, just before she starts, just to flag up, and this is something that we may have a short discussion on when Deb's made her report, that the role of integrated care boards in the NHS complaint system has still to be properly bedded down in the responsibilities that have been taken over from the clinical commissioning groups and the existing complaint system run in hospitals, which we have a part to play in. So there are points there about this annual report, but there are also wider points about the work that we're doing to try and design the complaint system so it fits with the duties and responsibilities of the Integrated Care Board.
Thank you, Chair. Yes, just to note, the annual report here provides the Board with an overview of the complaints activity throughout 23-24. It also highlights some improvements that have been made as a result of the identified learning from the complaint investigations. Also, just a point to note that this report covers the ICB complaints only. At this point in time, there is a separate primary care annual complaints report that will come to the Board at a future date. Just to sort of follow on from what Sir Liam said around some points to highlight in relation to the management of complaints. At the moment, that there are two separate teams managing complaints within the ICB, and this is due to historic arrangements as Sir Liam has described. We have a service level agreement in place with the North of England Commissioning Support. However, they cover the complaints relating to the ICB itself and its commissioning functions, but not primary care. The primary care functions, the management, of the primary care complaints function transferred over from NHS England to ourselves in July last year, which resulted in a separate team managing the primary care complaints. So we recognise there is a backlog in both of these teams in terms of responding to both concerns and complaints. However, we have put some measures in place to address this as a matter of urgency. We've commenced a series of improvement workshops, and these workshops are looking to re-establish the team as an integrated team to help build business continuity and resilience to ensure that this backlog is addressed. We're also looking to streamline the process because, as I've previously mentioned, there are slight differences in terms of the processes around managing complaints, which is, again, not helping towards the backlog. We're also looking to ensure that there is that appropriate clinical review undertaken in relation to complaints, because, again, there are some variances in terms of the processes around that. We also want to look to strengthen the learning element of complaints because, as we know, there's always lessons that we can identify, and we do need to make sure that we are identifying those and feeding that through to the relevant teams to support the improvements in patient care going forward. So we have just commenced these workshops and we're looking to do this over the next coming months. So we should, probably from the new year, have a new process in place which will streamline this, and you'll start seeing those improvements feeding through. The other point I would like to make is that we have increased the capacity within the teams because there were some issues in terms of the capacity to deal with the volume that is coming through. We are seeing an increased activity in the complaints and concerns coming through. So again, we're doing some work to address those. We're looking at the skill mix within the team as well to make sure that those more complex complaints that come through are getting the focus and attention they need. So we're looking to spread out that skill mix across the teams. And we do have some very experienced members of staff on the team with a lot of experience in complaints. So again, we're looking to make sure that we're utilising that in the right way to ensure responding appropriately. So I'll probably leave it there for now, Chair, but happy to take any questions in terms of anything I've just raised.
So opening it up now, Mike Smith.
Thanks for the report, Eb. It's really clear. I guess one of the things that's alluded to in the report or implied is just sometimes the delay in response. When there's a backlog, it then ends up being a slow response to any complaints, and that can further the harm created by the individual. I wonder, given the plans for improvement, whether it might be helpful to have a KPI for the average time taken to respond or to bring a complaint to completion, and have that included in our integrated delivery report so we can see the progress.
Yes, absolutely, Mike. Sorry, I should probably have mentioned that is one of the improvements we're looking at as part of the workshops to identify what a reasonable response should be to all complaints and concerns. Obviously that'll be addressed as part of that, and to make sure that the backlog is reduced as quickly as possible. And what we've done in terms of the additional staff that we've recruited, they will be focusing on the new complaints going forward, but then we're going to pull in other staff to focus on the backlog to get those quickly reviewed as quickly as possible.
John Rush.
Just whilst obviously it covers 23-24 and gives you a breakdown, is there a simple explanation in regarding the increase from the previous year or not? Or is it something, because it doesn't sort of analyse it at all, but I'd really like to just sort of understand it if there was something simple, or try and understand why that increase has occurred.
The simple answer is no, there is no simple answer to that. The activity, I don't know, a part of pulling that actual complaints function together has led to sort of looking as if it's an increased activity, but we are seeing a lot more volume from the previous year. But there's no real theme or trend as to why, it's just increased activity.
Okay. It'd just be useful to try and understand a little bit if there was a comparison between the 2 years. That was all. Yeah, okay.
If I may, Chair, yes, again, a part of the improvement workshop is to look at those themes and the trends coming through, and we'll pick that up as part of that work as well, John.
David Stout.
I wonder whether 22-23 was a part year for the ICB. So that may be part of the reason there. And while I've got the microphone, I mean, just to flag up, stating the obvious, but 42% of the complaints are around access to dental care. And until we resolve that, make progress on that, then presumably the numbers will remain high.
Dave Gallagher want to make a point about that?
Yeah, fully agree, David. It's not surprising that there's a high number of complaints there, but we are working on it, and indeed we're using the input from the complaints, but also wider patient and family input into their experience with dental to try and plan the service better. We've actually got a session later this week on Thursday looking at developing or agreeing the next stage of the plan that we bring back to board early in the new year. But yeah, it's a tough ask, and there's lots of pressures out there in the system at the moment. But I'd hope to see the complaints gradually start to reduce once we start to get a bit more grip and implementation of the work.
Sam.
Thank you, Chair. A couple of points I just wanted to share. The first one is I just wanted to say thank you to our complaints team, who it's been a relatively small team, highly dedicated and skilled, and been doing a huge amount of work. I think as we've started to pull in, if you like, all of the various responsibilities around complaints with the delegation of primary care from NHS England, with dentistry, and indeed with the multiple processes that existed in the predecessor organisations. I think it's clear from what Deb said, we're not quite there yet in terms of having a kind of a consolidated team, probably with the right level of resource, and that's why we took some decisions to put some additional resource into it. I just wanted to flag one thing that I seen as the Chief Exec is around some of the complexity of complaints, and particularly where people have touched multiple services, and I don't think we've been geared up in a way that sort of can respond to that. We look at everybody's complaint about every individual part of the service, and quite often complaints are touching several trusts, several different providers, and indeed just require a far more holistic review. The other bit of the organisation we've invested in quite heavily has been in our quality team. And I know, again, our quality team, led by Sarah Johnsfield, is working very closely with our complaints team in terms of how we provide a more personalised approach to complaints, which, for example, instead of a complaint being made in writing, doing multiple investigations involving meeting very early on with a complainant to get a full picture of the whole care that they've accessed in terms of how we can look into that working with multiple providers. So I think this is an area we've got quite a bit more work to do.
Thank you. Are there any other comments or questions on the complaints report? Okay, maybe we'll come back fairly soon with an update and as suggested, some statistics and so on. And I think I've highlighted in our internal meetings the importance of getting a good set of clinical inputs to complaints, because often that's the area that the complainant is most concerned about, that something may have gone wrong in their care, and then so you've got to get, and it's sometimes quite difficult to find people who have the expertise to do that. Right. Then I think we're sticking with you, Deb. You've got a lot of business to cover, and the next item is the standards of business conduct and declarations of interest policy.
Thank you, Chair. Yes, and this paper gives an updated policy in relation to managing conflicts of interest in our standards of business conduct. The policy sets out those individual and ICB responsibilities, along with the expectations that we would expect in terms of standards of business conduct. We have reviewed the policy to make sure it remains up to date and in line with the relevant NHS England guidance. The review did highlight for us that there was a bit of an overlap with another policy, which is around the commercial sponsorship and working with the pharmaceutical industry policy. This was causing a bit of confusion with the staff from having two separate policies, because obviously referring to, they weren't quite sure which one they needed to refer to. As a result, and obviously in consultation with the Medicines Optimisation Directorate and the Health Innovation North East and North Cumbria, it was deemed more appropriate that we combined the two policies together, and we developed a memorandum of understanding to help with the latter part in terms of working with the pharmaceutical industry. So the memorandum sets out a clearer framework to engage with and support new innovations, because although we do need to manage conflicts of interest, we want to make sure that we're not stifling that innovation as a consequence. So we have included a very detailed memorandum at Appendix H of the policy, and the policy was reviewed by the Executive Committee and they did recommend it for approval here today. So we're asking the board to approve the updated policy for staff. Thank you, Chair.
Okay, are people happy to receive that and approve it? Thank you. Then we move on to the board committees meetings, and each of them is now going to report the main matters that they discussed, and you should see a slide on each of them come up on the screen.
Thank you very much, Chair. We'll start with the Executive Committee. So in the papers today, we've got the minutes of the meetings of the 10th of September and the 8th of October, and a summary of the decisions and areas of focus in those meetings. I do just want to also just share with the board that over our last 3 Executive Committee meetings, we've taken the opportunity also to invite each of our local delivery teams into the Executive Committee. And at the recent committee, we had the North Cumbria and County Durham local delivery teams. And the format for these is that the local delivery teams give a presentation to the committee, and it's an opportunity for sort of two-way dialogue on all of the work they're doing. We have now concluded each of our 6 local delivery teams. I have to say it's been really informative and really, really valuable, particularly in strengthening the connection between us as an executive and deepening, I think, our understanding of the work our local delivery teams are doing, as well as areas in which we can support them. What's been really evident has been, I think, the passion and the huge amount of expertise we've got sitting in those teams. I think it's also been a real reminder that these are not huge teams either. They are I wouldn't use the word small, but when you look at the sort of the number of colleagues in them, and if you compare them perhaps to the teams that existed at that level prior to our changes, they are a lot smaller, and therefore it really requires the whole organisation to support and work with our local delivery teams in some quite different ways. The County Durham team, for me, really highlighted, I think, the real opportunities around integration. They're an integrated team working with a local authority. They've got quite a long history of doing that, and I think we want to really look at that model to think about what we can learn more from that. Our North Cumbria team, and of course they all bring their own strengths, has been really fleet of foot and quite innovative in their relationship, particularly with general practice and primary care, and thinking about kind of more wider community alternatives. And I would say North Cumbria is probably where we've got our most progressed neighbourhood model through the integrated clinical community. So how we get this learning across the Integrated Care Board is something that we're really committed to doing, and I hope that our colleagues found as much value in those presentations as certainly we did as an executive. And then just 2 other things briefly, Chair. Oliver McGowan training. So this is the statutory training that we receive funding from NHS England to deliver. We notice progress on delivery. Kelly, who is our new interim Chief People Officer, is doing some further detailed work at the moment on the implementation of the Oliver McGowan training, and also how we've been utilising the resources NHS England give us for that. So we'll definitely bring a further update on that through the committee and onto the board. And then just finally, I do just want to touch on GP collective action, and Levi may also want to say a few words on this in a moment as well. So I've reported through board previously that our general practitioners are engaged in collective action at the moment. We've had infrastructure in place in order to understand what the impact of that has been on local services, and we have started to see some impact on services. I do want to thank our colleagues in general practice who I think, in spite of the collective action, continue to work with us really openly in terms of sharing with us what steps they are taking. We have been doing seeking to do all we can within our gift locally to mitigate the impact of collective action on patients. To give you one real tangible example, some of this is related into the workload on general practice, looking at what's safe for a GP to see in terms of the numbers of patients. Some of our practices have been, for example, limiting that to a maximum of 25 patients. And of course, when you start to do that, it therefore also limits the amount of available appointments for members of the public face-to-face. And when we come on to look at our performance report later on in the meeting, we will see a slight reduction in terms of the overall face-to-face appointments. We're still doing a very large number, but we will see a reduction. At the moment, and obviously it's not for us to get involved in any negotiations with representatives of our general practice colleagues, but what we are seeking to do, as I said, is minimise the impact on patients and reduce risk wherever possible. That there is a risk, and I think, and I'll hand over to Levi shortly, Chair, if I may, there is a risk that we may see collective action and steps being taken increase over the weeks and months ahead. And of course, particularly coinciding at some of our busiest times of the year in terms of pressures on overall services. So we will absolutely do all we can within our gift. I just really want to kind of emphasise that our GPs are a hugely important part of our National Health Service. They are a very important part of the services we commission and plan on behalf of the population of the North East North Cumbria, and we're very committed to doing all we can to continue to support our colleagues in general practice where we can and where it is within our gift to both ease the pressure that they are feeling on services and look to do all we can to put alternatives in place for the patients as well, as and when we need to do so. But Levi, perhaps you want to pick up a few words on this too.
Yeah, thank you, Sam. Just to note, we previously updated the board, but we continue a weekly process supported by our strategic coordination centre with all of our local delivery teams. So we gather the intelligence on any new notification of collective action, so we can capture this, identify any local mitigations, but that also feeds a weekly process with NHS England, particularly focused for the North East Yorkshire patch. We are considering what our scope is around a GP sustainability scheme whilst we await some guidance nationally, including any changes to the contract for next year and the financial settlements. So very much working on a North East Yorkshire footprint with our other ICB colleagues to try and keep some consistency in our approaches. We are challenged because local medical committees have identified that if there are items in contracts anywhere else in the country, it could be deemed to have the same impact within the North East and North Cumbria. So for an example, if something specifically contracted, say wound management in Devon, one can make the case that therefore it should be specifically contracted in our ICB. So this is part of our regional and national conversations because that kind of clarity does not exist. Our focus locally continues to be around our local incentive schemes, our local enhanced service schemes for 25, 26 and beyond, to see where we can move to some consistency, which I do believe will be convergence over a number of years. It won't be starting from the 1st of April next year. And that reflects those historic contracts that we've had prior to the ICB, appropriately built on local funding arrangements, local services, including with secondary care colleagues. So we're maintaining, I hope, a proactive relationship with our general practice colleagues, and I'd echo what Sam says. Within the local delivery teams and all of the teams in the ICB, we hope we have good, positive relationships with general practice colleagues. They are core to what we do, and as colleagues in the room know, deliver over 90% of daily patient contacts. So We're just trying to bridge that gap between addressing the national impact of collective action and trying to do the best both for our general practice colleagues and our patients in the North East and North Cumbria.
Finished. Thank you. Any comments or questions on Sam's report? I'd just like to highlight one point, the Oliver McGowan training. And some of you may have already done it, I've done it online, and I found a very, very, very valuable package of material with very heavy use of video testimony of people's lived experience, but particularly the way Oliver's mother explained what had happened to him. And when I'd watched it, I asked myself if something like this was happening in our ICS, would our oversight mechanisms have picked it up? Would our new patient safety centre prevent it from having happened? Would our complaint system be able to react quickly enough to intervene? And my answer to myself was I would be doubtful about all of those solutions. And it seemed to me when I did think about it further that given that I've seen many both parents' testimony of children or young people who've died in care, that the similarity here is much more to do with the Martha's Rule territory, because there isn't, when things like this happen, essentially clinical decisions, clinical judgments, failure to listen to the parents, they're happening in a clinical cocoon. Nobody on the outside has got any way to penetrate that, and then the worst happens and you penetrate it by investigation and hearing about it and learning. So my question, and you may not be able to answer this, Sam or Levi, is Martha's Rule, if you are not familiar with it, was introduced following the death of a child in London in a London hospital who deteriorated after an abdominal injury, and for one reason or another, everything failed. And she died despite her parents expressing repeated concern. And as I say, with my WHO work, I've seen many such cases around the world. But there is now a mechanism that's been put in place in all hospitals in the UK for the ability of the parents' view to be taken account, and then their care is reviewed, escalated to higher levels. But I'm not sure whether that would happen in mental health or whether it purely relating to physical illness.
Yeah, thank you, Chair. My understanding is that does only apply within acute settings, but there have been initial conversations of the ability to extend that within a mental health trust. I think part of the challenge is how much more of the care within mental health and learning disability services is community-based rather than hospital-based. So we would need to look at a broad approach, and I'm sure Rajesh may well give some reflections from a Foundation Trust perspective. And I suppose just to provide some assurance, we do get the weekly report as an executive team around incidents, and we've certainly been seeing incidents or potential incidents relating to mental health and learning disability settings, which isn't just a reporting mechanism. I had a meeting just yesterday with colleagues about the interface between physical health and mental health providers and how we can improve the response for patients with comorbidities. So I think we're at the beginning of the journey, Chair, there, but there are some positive steps.
Yeah, I mean, I think the lesson for me on this is that education and training mechanisms are one of the weakest ways of assuring safety. It doesn't mean you shouldn't do them, but you're relying on every single member of staff to be fully aware of what they're required to do at every moment, and that's not a safe thing to do. So there is a need for some mechanism, I think. Anne, you wanted to comment?
Yeah, I would completely agree with what's just been said, and I think we are on the beginning of that journey of being able to answer that question that you posed at the beginning. So I think I would say probably no, we're not aware of everything at the moment, because as you said, some of those clinical discussions are happening within that bubble at that point in time. But I do think, as Levi alluded to, especially with the work we've been doing on the quality strategy, the work that we've been doing with access to the National Information Incident System, and the work with the BI team and Power BI, I think there's an awful lot of work going on that should help inform the picture and identify the opportunities for additional learning and intervention, linking with Boost. So I think the Safety Centre gives us a really good opportunity to draw all of those aspects together. And I do think that will evolve. And we're definitely, I think, being more aware quicker of any themes and issues that, as we can see in the Quality Committee papers, we've already acted on as well.
Thank you. I mean, just to flag up, we've spent a lot of time on this whole area of organisational culture and safety and responses in our board development events. But every time you come back to it with a practical situation, it throws a slightly different light on it. And it's important to keep looking at those different lights, I think. Sarah.
Thank you, Salim. I didn't mean to cause confusion before I put my flag down to avoid distraction. But no, I agree with your observation that the Oliver McGowan training is very useful. I, as a clinician, have found it very, very useful and very insightful, and definitely has changed my practice. Levi, I just wanted to touch upon the general practice collective action that Sam spoke of. And thank you, Sam, because I know all your newsletters have been very supportive towards general practice and highlighting this. I noticed in our Insight Over Delivery report that our practice in numbers have dropped from 344 to 341. I was just wanting to understand, is that because practices have closed or because they've merged? And is there any signals in the community that you're receiving to say that further general practice surgeries are under pressure or closing due to the changes of the NI situation?
Yeah, over the last probably 2 quarters, we have had a number of practice merger requests. We do have a formal process to go through those to consider the impact for the local population. So particularly thinking over the last maybe 3 months, we've had 2 in Teesside, 2 requests in Cumbria, and 1 potential one coming through in North Tyneside. So we have, a process for evaluating those considering the impact. They've tended to be more around either small, particularly in Cumbria, single-handed practices approaching retirement and opportunities for other practices to absorb that patient list, or where we've had some particular premises issues where it's meant we've actually expanded into larger footprints rather than sustain some old estate, which quite limiting in terms of clinical capacity. We're not seeing, I'm not hearing yet of national insurance changes having a direct impact on that, but we're absolutely aware with general practice colleagues of both the impact of national insurance, minimum wage, and particularly the additional role reimbursement scheme, and colleagues in the board will be aware of some of the guidance coming from NHS England in the last few months of how we monitor that with colleagues, because I think that's another area of potential risk for the year ahead.
Rajesh Nadkarni.
Thanks, Chair. In relation to the mental health question with regards to Martha's Law, that hasn't progressed, and fundamentally for one reason is trying to define serious harm, where serious harm is where you kind of effectively harm the person's health as opposed to are restrictive about their rights. So that work is going on, but I think what will help is the new Mental Health Act, which I think is in second reading today, I think, in Parliament, where the criteria for detention is going to be much higher, which in some ways will help us to then say, where could that Martha's Law situation be more applicable to the mental health sector? And the final bit about the ICB's role as how are we more vigilant, and I know you've been raising this for quite some time. I think we just need to, most of the times when you look at when things aren't going as well, there are lots of indicators around those which were already there. People knew about them, whether they are staff related, whether they are quality related, or whether they are patient experience related. And I think Jacqueline's work, which is looking at trying to get all that intelligent data, we've got, at the moment, the problem is we've got so much data that we don't really know where to look. my suggestion would be is that we focus predominantly around pathways and try to actually work with what data is available around those three areas and try to then be a bit more vigilant as to how we can provide support. And maybe the Patient Safety Centre will have a role in that.
Well, I mean, I suppose it's maybe the applicability of the Martha's Rule doesn't work in mental health, but the principle that you should first listen to the parent and take their views very seriously, and then if they want it, you should be able to call in an independent view. And I think however you design it, if you haven't got those two things, however complex and different the context is, I think you've got a problem. Anyway, Sam, do you want to, because we've spent a long time on your committee, so we better move on.
No, that's good. I think this is a really helpful discussion. Sort of 2 points. I know we're diving around a little bit. So just on this point, Sharon, I think your reflections are really helpful, and I think it was good for you to kind of share with us almost your learning from the Oliver McGowan training and actually how do we use that then to continue to strengthen our systems. I think as Anne said, we do have some green shoots, but we've got quite a lot more work to do if we're going to read the signals and use all of the data. And I think Martha's Rule, if we think about the session we did in our last board development on the Valdo Calacane learning out of Nottingham, listening to families, and I think in Martha's Rule that's just such a key point. Actually, how do we listen to families? So I think it probably is transferable, and we should probably really pick up an action for examining that through our mental health and learning disability services. I just wanted to briefly come back to the issue around general practice and primary care. I am starting to hear some real concerns from our general practices around the impact of the increase in national insurance, already starting to get some signals that this may indeed even impact their ability to employ people through the additional roles reimbursement scheme. So I think what we need to do as an ICB is really collect all of these points and advocate strongly for any changes to some of the requirements of these schemes that just make it easy to do the right thing. It would seem really odd if we're getting funding for additional roles and we cannot employ people to do those additional roles. That's just going to put further pressure on services. And if I may, Chair, as we go to next year, looking to next year, where we know that it's going to be another challenging year financially, we have to find some type of way of this GP sustainability package, but also how do we get this real left shift in funding? If we look at, I think, since 2019, appointments in general practice have risen by something like 35,000 a day nationally. So we're not seeing need drop, we're seeing need increase, more pressure put on the same staff, and also we're tying ourselves up in red tape now where we can't use the funding because of some national rules. So I think what we'll do is, through the process Levi's described, collect all of these issues through our general practices and make sure that we're using any ability we've got to challenge and ask for changes in rules with this funding so we can use it better.
Okay, thank you very much, and thank you everybody for your comments and questions on Sam's committee report. So we'll move to the Quality and Safety Committee now, so Pally Hungin as a chair.
Thank you, Chair. To continue with your theme about individuals and the care of individuals in specific situations, we at the Quality and Safety Committee are very aware of this particular point. We have a very wide remit. We receive a wide range of documents and reports which we review. But we start our meeting by reminding ourselves that each number on a chart is in fact a specific individual. And I think that's quite an important ethic. And if I might, by way of a summary of some of our recent deliberations, point to the middle section there. This is a patient story about a member of the hard-to-hearing deaf community who had enormous difficulty in accessing mental health support. Well, you can imagine how difficult or impossible it is to use a telephone if you're in trouble and you feel you need help, and how difficult it had been for this particular individual to get to the right service provider in a timely way. And we were very sympathetic to this, and one of the positive outcomes of listening to this patient's story was our will to take this further to see what we could do about helping people who had such communication difficulties, and how we as an ICB and our providers might respond to this. So this may seem like a small item within a huge agenda which covers the large landscape of our ICB, but we are very much aware that quality is based on the individual, at individual level. And I want to heartily commend your comments earlier about what we do in specific situations. Also in the middle category there around patient stories, we had a discussion about patients who were in care, specifically in hospitals, who might be discharged, and if they'd been in hospital or in whatever care situation they'd been for a while, sometimes they actually end up losing their home accommodation, and they either have to go into a situation where they might be living out on the street, or not be able to go somewhere to a familiar setting. And you might say, well, this is very little to do with health provision, but in actual fact, it's everything to do with health provision in terms of preventing readmission and other factors. So I'm pleased that the committee is starting to, or has done, in fact, for a period of time, listen to these wider concerns so that we can start over time to delve into them in a more meaningful way, perhaps liaising with local authorities and other providers of accommodation. So the only other points I want to raise are points that you are probably aware of, that there is a national difficulty with regard to the provision of paediatric audiology services. And we, in our own patch, are keen to ensure timeliness and high quality provision of paediatric audiology services. And I can assure you that we are monitoring the situation closely. Much work is going into improving things, and I anticipate that in the coming year we will have improved this access difficulty. The third item I just want to raise your to bring to your attention is to do with the complex care incident management, particularly in the Tees Valley, and this has been a problem in the past, largely because of personnel and resource issues, but I'm pleased to say that this is now under much better control, so this is a nice positive message. And the final item there, which was to do with concerns and complaints, well, thank you for having dealt with that in some detail a few minutes ago. So that's all I have to report from our last meeting, which was on the 14th of November, and you have the minutes of our previous meeting from September there already.
Thank you. Any questions for Sir Paley or comments on what he said? No? Well, thank you very much for that comprehensive report. And we're moving now to the Finance, Performance and Investment Committee, and chaired by John Rush.
Thank you, Salim. Again, you'll see on the actual initial report, there's the minutes there from the 5th of September and the 3rd of October with the various points that we discussed there. But I just want to talk about some of the activity that occurred in the November meeting. So as regards finance, we supported a letter to go back to North Cumbria for their electronic patient record that they wanted to get in place. It wasn't a matter of funding it, it was just a letter of support. And having, so you say, worked and lived in that area for a long time, the idea of getting an electronic patient record in North Cumbria is very much appreciated. The other things that we got there, we got updates obviously on the financial position, including the funding that we received from NHSE to assist with the deficit. And I know that David will probably talk a little bit more detail about that when he comes onto his particular report. And then really as well, just some of the pressures, which I know Sam's already alluded to financially, around some of the NICE approved drugs and devices, and also as well prescriptions, etc. And I've now lost my bit on there. Hold on, let me get this on my screen. So they were the main of the financial issues. Going on to performance, the thing for us on the performance side, we're obviously concerned around urgent care and some of the demands on ambulances, etc. Although it was noted there was some significant improvements in relation to ambulance service. But the other side to it as well, we struggled a little bit in terms of trying to understand the performance and the whole plethora of it. And we were very well supported by your colleague, Jacqueline Craig, who came along and reflected back to us some of the things that came from the development session. I wasn't present at the development session for reasons that you'll be aware of. But talked about trying to get a little bit more in depth and get behind some of this performance and analyse it a little bit more. So hence why, yes, there are challenges in terms of our performance, particularly around urgent care, and also as well, particularly in trying to meet the deadline for our 65-week waits for December. We then took on board the idea of doing specific deep dives into real areas of the challenges that we face, and we came up with a prioritisation list that you can see there in terms of the ones that we're going to have at the following meetings in January, March and May to do with diagnostics and the impact on elective and cancer recovery, the primary and community care in March, and then mental health again in May. We were very grateful that we've previously had reports on mental health and learning disabilities provided to us, and Levi is a member of the board, but also came and presented it to us, and also as well then brought that onward to the board. So we are obviously the committee that is in the governance structure for the infrastructure board, and James Duncan came along again to give us an update on where we were with the strategy, the infrastructure strategy. And interestingly, the main parts of the conversation was just trying to work out, in terms of prioritisation of what we're going to spend our funding on in capital funding, the process for that. Now, I know James is very keen because to get that to the ICB at the beginning part of next year so that we can sort of sign some of these off. So the process, I'm hoping, is that, and I still need to clarify this with James, is that we can get at one of the next finance performance meetings our support for that or consideration, and then get it to the board as soon as we can in terms of that timescale so we can get it signed off. So still working on that, but it's useful being that committee that does receive James's input about the strategy. I think that's a useful process for us. And then final bit for us, we've talked a bit about prevention, and it was a question a number of months ago from Mike about how do we know how much we're spending on prevention. And we set off, and David and his team, should we say, tried to unravel that for us. And it's not as easy as you think, is what I would say. So the report that we got back was just expressing how difficult it is to decipher exactly what goes into prevention and what's on just the normal type of, say, acute care or primary care. But also, as well, it opened up a wider discussion that we're very grateful to, and I think Eileen was part of that discussion, that there are other areas where prevention is discussed across our ICS, across our whole area, and that we could link into. So whilst it was a challenge, I think there's still some work to do, and I know David and his colleagues are trying to link in from a finance perspective to some of the other, say, committees within our area and work out, well, can we try and get an idea of what this would mean? And even if it was just something that shifted us from, say, 10% of our budget to 15% of our budget that we could do on prevention, as an example. I don't mean that they're the actual figures, by the way. I just use that as an example. But one thing that we did come out of it was it is a very complex area to try and work it out. But also we said, well, there might be one or two prevention type programs where we make a shift. So we use as an example, okay, well, if and when the drug that's being used to support people in weight loss, if there is money going into that, what is that resulting in terms of maybe obesity or diabetes later down the line, can we show that the money invested into that is actually paying off in terms of people being healthier and living longer lives. So there was things where you could maybe just choose a particular topic. So I think that was probably an overview, really, of where we got to in terms of that committee. Thank you.
Thank you, John. Comments or questions? Graham Evans.
Yeah. Thank you, Chairman. Just to confirm from John's points, within the Infrastructure Board itself, we have established a subcommittee that meets each week to ensure that we've got the right governance and lines of accountability. We're also waiting the outcome of our submission of our strategy, which was submitted in July of this year. And once we've received that, we can then look at the recommendations and the priorities in line with the role that John's described. Thank you.
Thank you very much. We move on now to the Audit Committee. David Stout is the chair.
Thank you very much, Chairman. Just let you go through the highlights of the meeting on the 10th of October. Slide is up there. We start with Risk Management Board Assurance, and we had the report earlier today. This is a standard item on the Audit Committee, Risk Management Board Assurance. At the last meeting, we were told that the executive team had agreed a standardised approach which would be used by staff in handling risk management. So they've agreed that a standardised approach, roadshows are being carried out to train and support staff in adopting that approach. And the Audit Committee were informed that as a consequence of that, the standard of quality has increased around risk management as a consequence of standardisation and training. So that was really good to hear. Finance update, we receive every month an update on the financial position, not in as much detail as the Finance and Performance Committee, because we don't want to duplicate what's carried out there, but we do get the headlines there with the Audit Committee. And we also look at things that the Finance and Performance Committee don't look at, which is levels of debtors and creditors, tender waivers, losses and compensations. So we do that routinely, and the Audit Committee was happy with what was presented to them. There is something called a Mental Health Investment Standard, which is the NHS executive, and has done this for a few years now, asking the service to provide independent assurance that they've been providing enough resources or enough new money into the mental health area. This probably goes back many years when mental health was Cinderella service, and there was a fear that resources, not enough resources, extra resources, were going into mental health. We decided some time ago to use external audit as our measure to ensure that we have complied with the standard. And at the last meeting, we had a report from external audit confirming that they had actually done the work, and they were happy to give that assurance. It's a conditional assurance, because technically it's like trying to work out how much to spend in prevention. So there are formulas that are applied, but we have been consistent. We've used the same methodology as an ICB that the CCG has used previously, and NHSE was quite happy with that. So we've continued that process as an ICB. So that was fine. That should be the end of that bit of work. Internal audit, the executive team have carried out a mid-year review around the internal audit programme, which is very sensible to do in any case. As a consequence of logistics and to free up some resources, 4 internal audit planned audits for the current year have been deferred into next year. The reason why we try to create some headroom within that, you'll know from the finance report, from David Chandler's finance reports, that in fact a lot of work is being carried out with foundation trusts, and internal audit have been involved in that, looking at the systems around grip and control of spending, and that required resourcing. So we've helped by freeing up a number of audits in the current year and deferring them into next year. That's created the capacity to help that work be carried out for the foundation trusts. So that was that. And I think the last thing I want to cover is the annual review of external audit and internal audit. Every year the Audit Committee formally reviews the performance of external audit and internal audit. At the meeting on the 10th of October, we formally reviewed the service provided by external audit, and we were happy with that. And we've done a letter under my name on behalf of the audit committee, giving feedback to the external auditors saying that we're happy with that. And we've also now agreed a process for reviewing internal audit, which is like a 360-degree process involving members of staff within the ICB who have been working with internal audit to get feedback that, in fact, at the end of the day, the reports have been handled efficiently, effectively, and are useful at the end of the day. And we will formally consider that at our meeting in January. So that's what we did at the last meeting. Thank you very much, Chair.
Thank you, David. Any questions or comments for David Stout? No? Right. Well, thank you. We're moving on then to the items that are grouped under quality planning and delivery, and starting with the integrated delivery report delivered as usual by Jacqueline Myers, Chief Strategy Officer.
Thank you, Chair. So as in previous months, I'm just going to draw a few key changes in the main report to the board's attention, but otherwise take the very detailed end report as read, and we'll of course always take questions on it. And then I'm just going to bring the board up to date with the latest published data in relation to the key performance highlights. So starting with the overall report, just of note is that there's a new metric this month in relation to the community mental health services that are provided by our primary care networks, which is worth having a look at. And also, since the last board, we have been required as an integrated care board and system to submit a set of 104-week wait elimination trajectories in relation to community mental health services. We weren't able, unfortunately, to land a plan which got us to 0 for all of those services by the end of March. The plan that we submitted does look to eliminate over 104 weeks, which is obviously 2-year waits for adults, but our plan suggests that we won't be able to get below about 560 patients waiting in the children and young people services. These long waits relate to the neurodevelopmental pathways and services that we've discussed a number of times at the board before. And I would just note a couple of things in regard to that piece of work. Firstly, that these are new definitions. They are somewhat limited in their scope, relating only to community mental health services, and there are some challenges we're working through in terms of ensuring that all of the counting is done in a common way across all of our providers. The second thing I would note is that in order to achieve that elimination of 2-year or 104-week waits for adults and a reduction down to 560 for children and young people, that represents quite a significant improvement on waiting times compared to where they are today. So it relies on a lot of actions that have been identified to be followed through and delivered in order to get there. But that's a big a piece of work that's covered in the report and worth noting. And then lastly, in terms of the main report, I just wanted to note that there are a number of new metrics relating to our Healthier and Fairer programme led by our Chief Medical Officer Neil, which are really setting some challenging targets and providing you the current position in relation to inequalities for either in relation to deprivation or ethnicity, relating to a whole range of care processes that people receive, for example, the control of hypertension in primary care or uptake rates in vaccination or screening programmes. So again, really worth a look, and where possible we've provided some national benchmarks. So you'll see, looking at those data, that generally, although not exclusively, we perform reasonably well in terms of the level of inequalities in those pathways compared to other parts of the country, but there are still really significant inequalities occurring, and we are looking to take action to address those. So those are just the things I want to draw attention to in the main report, and then turning to the slide that we're sharing with you this morning. These are the data that were published on the 14th of November, so after the main report was developed and went through our committee system. So just to bring you up to date on a few key headlines. So thinking first of all about our ambulance response times, unfortunately after many months of improvement we have seen a second month of deterioration with the category 2 response time going out beyond 30 minutes for the first time this financial year to 31 minutes and 8 seconds. Still benchmarking relatively well across the country at third out of 11 ambulance services. And great to note that we're still delivering the 7-minute standard for category 1 and we're still the best in the country for that, but of concern as we enter into the winter period. And so we're working with the ambulance service to look at potential mitigations to that. As our Chief Exec and commented on earlier, working very closely with the system to respond at times of pressure. The A&E 4-hour target has also taken a second month of downturn, was at 75.8%. These are the October data, so again of concern. That's actually recovered slightly in the November month to date, which is good to see, but nonetheless we are now sort of diverging quite significantly from our plan for the year, where we hope to maintain that standard at over 80% for the month just gone. Looking at the cancer performance, you'll see there the headline 792, that's the lowest number of people we've had waiting over 62 days for either a benign diagnosis or the start of their definitive treatment if they have received a cancer diagnosis that we've seen for a number of years actually. So it's good to see that number coming down, and below that the 65.8 is the percentage of people who were treated or discharged, so had their journey completed within 62 days. That's slightly below our plan for the month, but we are sort of, you've still got a kind of green arrow over the recent months. We've had a statistically significant improvement against that, and I think we're still looking in reasonable shape to deliver the 70% by the end of the year, which is the national target. Turning to elective or planned care, you'll see there that we still have a significant waiting list for our 3.1 population, with almost 356,000 people waiting for procedure. Well, I should say people waiting for procedures. There is some duplication in there, so it's not all individual people. There's about 4 or 5% of people waiting for more than one thing. But in terms of the very long waits, so the over 1 year waits, the over 1.5 years waits, and so on, all coming down now and consistently for a number of months. And so you'll see there the 65-week wait, we had 329 people waiting there at the end of September, because we're on September data for electives. So I have to note for the board there that we didn't, we now have sort of official confirmation, as I trailed last month, the last meeting, that we didn't meet the national ask to eliminate 65-week waits by the end of September. And as I think John, our Chair of Performance and Finance, mentioned earlier, that's in common with pretty much the entire country, and a revised date has been set at the 22nd of December to achieve 0 waits for 65 weeks, with some accepted national exceptions, and they relate to a couple of things. Corneal transplants, where the availability of tissue means that there will be quite a lot of people waiting nationally still for that procedure, and some waits around specialist spinal services, where there is again a national challenge around that. So within the ICB, we've set a plan of getting to 85 patients waiting for 65 weeks by that national deadline that's been accepted by the national team, and we're working hard to deliver that. And then lastly, just in terms of these data, looking at the mental health waits there, you can see that the reliable recovery standards, they've nudged up slightly, but still not quite meeting the national standards. And the numbers of community mental health activity numbers are still exceeding our plan and looking fairly healthy. At the bottom, in terms of primary care, both GP practices and dental, I think the picture there, without going into lots of detail because I know we're tight for time and want space for questions, it is a picture under pressure. So you can see we've got downward arrows there that indicates for a number of months now we've been seeing a reduction in the percentage of our patients who are seen within 2 weeks, and the numbers that are seen same or next day. We're not seeing that continued growth month on month that we were seeing last year in GP appointments. It's pretty steady, and I think that probably recognises some of the pressure and concerns within the sector. In terms of the dental plan, we're delivering 72.3% of our very ambitious plan, so we're not getting as far as we hope to, We benchmark well against the national position at 41%, but still some distance to go there. So hopefully, Chair, that gives a quick run round of the highlights. And as ever, I'm happy to take any questions in relation to the full report. Thank you.
Thank you, Jacqueline. David Stout.
Jacqueline, thank you for the report. It's very, very comprehensive. In those areas where we need to improve, I'm conscious from what you've told us previously that you get in support from wherever it might be. And I wondered, I mean, that might be NHS improvement teams or elsewhere locally within the North East or maybe even nationally. And I wondered whether they actually have been really helpful and whether there are any lessons to be learned from that. And whether, in fact, given that lots of these have been a problem for quite a while, whether we've reached saturation point, and in fact, actually, we've gathered as much useful information as we can, but actually we've still got a problem. So I just would welcome any comments around getting expertise to help the situation, really.
Gosh, well, I think that's a very big question that, we perhaps give a 3-hour seminar in response to. So I'll do my best to do it brief justice, and perhaps a further conversation at Board Development Day might be the opposite way best way to deal with that. I think there's, we work in a complex, multi-layered system. Often it's developed in a kind of piecemeal, organic way. And so very broadly, what I would say in response to your question is there's still lots of opportunity to learn and improve. And I would not suggest that we're at saturation and we've learned everything there is to learn. So I think there's still always opportunities to improve. I think the kind of flip side of that is in such a sort of pressured and complex and multi-layered, multi-professional environment, it's sometimes difficult to deliver and sustain change in practice. So I think, whilst there's opportunity, taking that opportunity and making the difference is perhaps not always as straightforward as we would hope. The second thing I'd say, Chair, just in response to that, to give you a very short response rather than get into detail on any particular area or programme, is that we are very cognisant of our role as system leaders and conveners to think about how we support the system to learn and improve, and that's why we've developed our Boost Learning and Improvement System, and we do reflect on and consider the relative merits of different approaches. So one approach that we've found particularly sort of efficacious in recent years is structured peer review and follow-up, and we've found that that's well received and seems to sort of penetrate and impact more effectively than some of the kind of parachuting in teams who have a regulatory role. So we're just in the process of codifying our approach to peer review to put it together as a support package that we can deploy flexibly in different teams and in relation to different packages. So I guess we are very thoughtful about that very question that you're posing there, which is what are the opportunities to improve and how do we best make them happen?
Thank you very much. That's very, very helpful. Thank you.
Sam.
Thank you, Chair. I just wanted to ask around virtual wards. I know this is a conversation we've had in the Executive Committee, and we've got quite significant underperformance in virtual ward capacity. And it's a bit of an open question, perhaps to yourself and Neil and anyone else who wants to come in on this, with the permission of the Chair. At what point do we sort of pivot away from our investment in virtual wards to different models if we are not going to be utilising the capacity there, particularly given the pressure on general practice?
I mean, I can start if that's helpful, Chair. So it is something that we're very, engaged in as a question at the moment. And we're just doing a piece of work in our Living and Ageing Well partnership to really get underneath how our virtual wards have been set up, what's the difference in, because there's quite a significant variation in the staffing models, in the pathways into virtual ward, in the ways that they're being utilised. So we will shortly have kind of very detailed assessment, including quite a lot of soft intelligence from the ground. I think it's still evolving. So we do know that only about half of our virtual wards regularly receive what we call step-up admissions from the community, as opposed to solely taking admissions from hospital as part of a sort of discharge arrangement. So that we know there are still opportunities to utilise that that model more than we do. But I think, as you intimate, we do also need to consider how long do we continue to iterate that model rather than think about alternatives. I guess what I would say is that if we think about virtual wards in a very broad sense as a way of holding a virtual caseload in the community, some approach that includes some of the facets of virtual ward is likely, I think, to be a feature of our community services in the future. But the way the national programme was set up perhaps was less flexible than we would wish, and we might want to revisit it and reshape it quite considerably. I don't know if others want to.
Neil, anything you want to add?
No, I think, as I say, there is a review underway at the moment. As to when we make the decision, Sam, I think we've been working with virtual wards since COVID, and they were brought in very quickly. And the clinical model, has adapted and changed and been implemented in different ways in different parts of our patch. So we're trying to get some consistency. I think the best way to look at it would be how the virtual ward models, in relation to the development of our integrated neighbourhood health or team approach. And I think that's what we're starting to work on, and that's certainly going to be a priority looking forward. I think we still need some more time with this model as we develop our integrated neighbourhood health model, probably for the next year or so, but we do need to start seeing utilisation rates improve.
Thank you. Sarah Melick.
Thank you, Sam. You mentioned one of my questions on the virtual wards, because obviously when we talk about the left shift of the hospital to community and analogue to digital, virtual wards are very much a signal of our system, aren't they, to move in that direction and help with the prevention agenda. Jacqueline, my other question was just around clarity of appointments. So obviously we have a very clear understanding of general practice and the number of appointments that are delivered, and maybe this would be for a development session, I accept that, but I just didn't know what the true demand on the system overall was, and I think that would be really useful for our public population to know exactly how many appointments are being delivered in pharmacy, how many are being delivered in the hospital. So I think, you know, we have one part system micro data, but we don't have the full system data as to actually we could be delivering over 4.5 million appointments a month in the system for all we know, and I think it's just useful for our public to know that and understand the supply and demand that we face. But I was also curious about the additional roles as well. So we know that 1,515 appointments are delivered, but I didn't know how effective or efficient that number was. So if you have any insight into that, I'd be keen to hear it.
Thanks, Sarah. I think that's probably one to take away and come back to at a future meeting. I mean, we do have very detailed data on hospital appointments that we could share. In terms of the kind of broader teams within primary care, I don't have those flowing into this system at the moment. We can go away and look at what we can get. I think the other thing is that there are whole lots of other ways now that GP practices, as you all know very well, Sarah, deal with demand, which doesn't necessarily count as appointment. They deal with online queries. You know, there's all sorts of other, you know, in the same way we have things like advice and guidance in hospital practice. So, you know, I have a sort of related thought, is that how do we best understand how we're meeting the demand and the need out there, and is it effective? And I'm not sure that just counting appointments gives a rounded picture and even drives the right behaviours necessarily, because it's very episodic and doesn't necessarily reflect the kind of effort that goes into managing long-term conditions by the multidisciplinary team. So I think there's a big piece that we could do on this to get a better sense, not just of the amount of activity that is going on out there, but how well all of the activities that we are doing, other than episodic care, are contributing to supporting people to live well and with their conditions. Thanks.
Thank you. If there are no other points, can I thank Jacqueline again for the report and to your team for the work that's gone on behind you. Move now to item 14, which is the finance report, and David Chandler, Chief Finance Officer, is going to cover that.
Thank you, Chair. So I'll take the report as read, but just pull out the key highlights from the report for everybody. So this is the month 6 report. I'll start with the ICB duty to achieve a surplus of £53 million. We now have sufficient data to provide information to the board about how that's going. You'll remember things like prescribing and packages have a 2-month delay in terms of data. But for the ICB, we are just ahead of plan at month 6. And despite some prescribing pressures, which I'll come on to later, we are assuming and working on the basis that continued underspends on things like running costs, high-cost packages of care and reserves will enable the ICB to achieve its forecast downturn. In terms of the ICS duty to achieve its financial deficit plan of £49.9 million, Remember, the ICS is the ICB plus the foundation trusts in this instance. We have now received that £50 million of promised deficit funding from NHS England. That's non-recurrent monies. It's been paid out on a fair share basis to those trusts with deficits. So whilst that's good news, it means we can report break even on at least a non-recurrent basis. I just think it's really important the board recognise and acknowledge that that money is repayable if we don't deliver break even. So if we miss our plan by £1 million, we in essence will get an invoice from NHS England for £51 million. So the importance of delivering our plan is emphasised by that. At month 6, I'm able to report in the report that the ICS, both in terms of year-to-date and forecast outturn, is on track to deliver. However, at month 7, which obviously is not in the report because it's a month 6 report, we are now starting to see the continuing pressures in areas such as high-cost drugs and now the pay award starting to have an impact on the ability of the ICS to deliver that plan I've just talked about. We've got some more work to do on the pay award just to understand why the funding doesn't appear to meet the cost of implementing the pay award or the high level of pay award. The initial assessment suggests that maybe there's a shortfall or risk of around £20 million to the ICS. But we do need, I stress, to do some more work in terms of understanding that figure, and that figure may well come down, but certainly we are initially seeing some risk and pressure in that area. The other pressure, which I talked about earlier, was around continuing pressures in high-cost drugs and devices. And that's mainly relating to new NICE approvals. Diabetes is probably the main area, and that's added about £25 million of cost to the ICS this year. To give you some sort of sense of scale, that's about 2.5% of what the ICS spends on medicines in a typical year. So it's a significant pressure on effectively just one item of that makeup. Of course, those drugs and devices offer value for money per NICE approvals. The issue of the ICS is affordability. So whilst these drugs and devices offer value for money and they're clinically effective, the ability of the ICS to actually fund and pay for them at that level of scale of impact is challenging without making savings elsewhere. That is something I'm picking up with other ICSs, with the medical director and with NHS England in terms of the affordability question. In terms of financial risks then, I talked about some of them earlier, but if you remember at the start of the year we had £160 million of unmitigated risk, and obviously that's a very high risk plan to deliver for the ICS. We have at month 6 been able to reduce that down to around £60 million of risk, and I've touched on a few of those risks already. There's also the risk of Band 2 to Band 3 regrading issues in some of our provider trusts around healthcare assistance. So when you take all those things into account, we do still have risk in the system to be able to confidently assure the board we will deliver plan. We are working both as a system and with NHS England to identify and manage that risk. I'm confident we'll bring it down. I'm concerned it will require difficult decisions, though, between now and the end of the year. And obviously, we will take those difficult decisions through the appropriate governance processes. On capital, probably a bit more of a good news story in that area. We are confident that work via the provider collaborative, some additional brokerage funding and some additional resources received from NHS England, that we're confident we'll be able to deliver our capital plan this year. To be honest with you, there's more risk of an underspend on capital than there is a risk of an overspend at this point in time. But I'm confident that working with partners up and down the patch, that we'll be able to land the capital plan for the year. In terms of final points, David mentioned the work that we commissioned around the ICS financial grip and control work. Those reports are now effectively concluded, and we'll be taking those through the appropriate governance processes, through audit committee, through the finance and investment committee. They'll also be going through the audit committees and the like, through the foundation trust as well. There are some things that are coming out of that work. They are things such as our controls are pretty good, but they could be improved in certain places. So there's some good news on that side of things. But also things like our PMO functions across the patch, they can be improved in certain organisations. And one of the big ones is our efficiency pipelines. So the ability of our patch as a system to identify and implement recurrent cost improvements could be improved if we strengthen our pipeline. So that's basically every single year you've got 2 or 3 years of things that are coming through a pipeline that you'll be able to implement each successive year. So some organisations do that better than others, and part of the work that we do from the grip and control work is to share some of that learning across the piece. The report talks about the medium-term financial plan. That now has been updated. It's going through various forums now, and again, we'll come to the board in a future meeting. The initial estimates from that financial planning work suggest that for 2025 and 26, so next financial year, we're looking at as a region to need to deliver efficiencies of around 4 to 5% next year. Now, as Sam alluded earlier, we haven't actually got the formal planning guidance yet, so we'll have to work that through in terms of how does that affect the financial planning work that we've done. But certainly, it's going to be a very challenging year. To give you some context, this year's recurrent efficiencies are around 3%. If we have to deliver 4 to 5%, you can see that's going to be very, very challenging indeed. It's important to stress, though, that the planning work for 25-26 has commenced already. We aren't waiting for the planning guidance. I think that's really important in terms of identifying and ensuring we've got implementation of efficiency programs from the start of the year, not sooner, rather than delaying them until midway through the year when you need effectively double the impact if they start at month 6. So they're the main things I wanted to just to share with the board chair, and more than happy to take any questions.
Thank you very much, David. David Stout.
Thank you very much, Chairman. Thank you, David, for a very clear report. My question actually is the very last item on your report, which is a workforce schedule. And if I'm reading this right, what it actually says is over the last 12 months rolling average, on non-medical and non-clinical substantive whole-time equivalents have increased by 2.5%. And that just seems to be a very good reason for that, or the numbers may be wrong, but that just seems counterintuitive, bearing in mind that we're trying to make recurrent savings. Now, I'm not asking you to answer that question now, because I would imagine that'd be quite tricky, but I want to flag it up and just be assured that the processes, the governance processes that we've got, would be looking at that line in particular, because it's 522 members of staff.
Yeah, so just to confirm, David, already picked it up. We are picking up in terms of the quality of the data, and is that really happening or not, and what are the drivers behind it. So I've already picked that up with the ICS workforce workstream lead in terms of why does it say that. We are seeing reductions in spend, and we do know that we're also seeing some transfers of services from PFI providers into trust. There's a combination of things happening there. Yeah. But your question is, can you be assured that we are picking up on these things? Yeah. And the answer to that is yes.
Yeah, okay, thank you.
Any other points? I don't think so. David, thank you very much for your report. These are matters that we've been asked to note. There's no decisions being made by the board today on financial matters in David's report. Right, moving on then, before we break for lunch, to item 15, which is the Voluntary Community and Social Enterprise VCSE update. And as I mentioned earlier, Dan Jackson is deputising for Claire Riley on this report.
Yes, thank you, Chair. And this update builds on a presentation that Claire gave, I understand, in April to the board this year, which gave an overview of national guidance around the expectations on ICBs and how they should work with the voluntary sector, an overview of our VCSE partnership programme, which is led for us through VON, and the development of that partnership and its emerging priorities. And as part of that update, I think we committed to undertaking a piece of work which we've called a stock take, which I'll come on to. But I think it's important to recognise at the start that the voluntary community and social enterprise sector, the VCSE, as I'll refer to, is a really important delivery partner for us. An extraordinarily diverse sector across the North East and North Cumbria. We estimate about 16,000 organisations of various sizes work in this space. And it's a sector, I think, characterised by extraordinary levels of commitment and energy and innovation. And it's a sector that we want to do as much as possible to support and work with. You'll see from the report that we've tried to estimate our current levels of investment in VCSE organisations through contracts and grant giving. That was quite a challenging exercise to undertake, and it reflected the fact that there was a number of legacy arrangements from 8 CCGs into one ICB, but we came up with a figure of around £38 million that we think the ICB invests in the sector. But that doesn't cover the entirety of NHS investment in VCSE organisations, because our Foundation Trust colleagues and others also invest in the sector, including through their charitable arms as well, which is an important area that we're getting closer to. I should say that this stocktake paper was written before the latest NI increases, and that's causing some considerable concern amongst the sector and may affect the viability of some VCSE organisations that we need to be very conscious of. And I think, much as we as commissioners would want to fund, an enormous range of VCSE organisations, we have to be quite discerning in what we invest in, and we can't fund everything, obviously, so it's important to focus on evidence and outcomes, and that's one of the issues that's picked up in the paper. But I think it's also important to mention that where this work, our relationship with the sector fits in with that broader fourth objective of ICBs, how ICBs can contribute to social and economic development. We've already seen the announcement today of the North East and North Cumbria as a health and growth accelerator, and VCSE organisations will play a really important role in that space, and we're keen to work with them on the delivery of that programme. You'll have also seen the work we're getting underway in terms of our anchor network that our foundation trusts have committed to, in terms of how we invest in local economies, local foundational economies, how we recruit from local communities, and how we support the voluntary sector to flourish in all of the communities that we work in. And then finally, those three key shifts that are uppermost in our thinking. Again, the VCSE plays a really important role in helping us to achieve those objectives. So just returning back to the purpose of the stock take, I think we wanted to better understand what we currently spend with the sector. As I've mentioned, we've carried out that analysis. We also wanted to conduct a piece of policy analysis, I guess, on what the emerging thinking is around how public services can work in this space. It relates to Sam's point about public service reform as well. And you'll see we've tried to summarise a range of national reports on the importance of partnership working in this sector, from NAVCA and others, the Inequalities Commission, for example, the work of our community foundations, which are really important partners to us, the work of other ICBs as well, and you'll see we've summarised some of the work that's been done in Greater Manchester in this space. And we've also wanted to capture some really interesting case studies as well of how the VCSE sector really makes a difference for our communities. And I just draw your attention to a really interesting piece of work carried out by UCL, led by Professor John Tomini, who's helping us with a review of our integrated care partnership arrangements. And John's team led an investigation into social infrastructure in Sacriston in County Durham, not far from here. And the conclusions of that report are really interesting and pose a challenge to policymakers, in terms of how we best support that social infrastructure that's helping to meet unmet need in communities like Sacriston. And there's a range of other examples in there as well. But we also wanted to draw on the work that the VCSE Partnership Programme through Vaughan and Cumbria CVS have helped us with in terms of a temperature check. And you'll see the summary of some of the key areas of feedback from that. Some of the progress we've made as a partnership, but also some of those issues that cause some frustration for VCSE organisations, particularly around their full participation and engagement, but also practical and concerning issues around full cost recovery, for example. Sometimes colleagues in the VCSE sector tell us that clients are referred to them by statutory sector organisations without necessarily always the funding to follow. And that's an issue that we've committed to address. And also that perennial issue around longer term funding, which is a challenge for organisations who are often have to live hand to mouth. And how can commissioners better support the sector with longer term funding packages? And you'll see that's emerged in the recommendations we put forward. And again, how we invest in infrastructure more broadly. You'll see the map of local infrastructure organisations included in the report. I think there are about 17 at the latest count, but they're really important local infrastructure bodies that help the sector to flourish, to help them with guidance on governance and financial matters, but also a kind of volunteer matching service in some cases. And the sort of infrastructure bodies that I think we need to do more to support. And I'm grateful for Lisa to pointing out that some of the names of those organisations in this report have changed again since this report was written. So we'll need to update that graphic. So finally, just turning to the recommendations we've made that have tried to respond to all those areas of feedback, particularly through the temperature check report. We've broken them down into kind of strategic level, system-wide recommendations for us, which include refreshing our partnership programme structures and the strategic advisory group potential for a group like that to work closely with us in terms of understanding the priorities of the sector, building on the work that's already underway through the partnership programme, and providing that space for us to explore areas of common concern with the sector more fully. To set out those refreshed arrangements in an MOU, which many ICBs have already undertaken and signed off, and we'll set out those in a document that'll capture that kind of our commitment to working with the sector and how we're going to address their concerns and fully engage them in all of our work. But also some other practical issues like involving VCSE sector leaders in our own leadership development programmes, ensuring full participation in our Boost learning and development system, for example, strengthening still further those communication mechanisms, because try as we might, such a diverse sector, we can't reach everyone as hard as we try, and that's something we need to continue to work on. And then interestingly, and we're really grateful for the leadership of Lisa Taylor and colleagues at Vaughan on this, we've secured that funding through Assura to do some developmental work on a standard grant making and commissioning framework that can help us as ICB commissioners to better support the sector. And within that, ensuring that we take a balanced and proportionate approach to impact measurement that is realistic given the size and scale of the organisations that we're often working with. And then also just develop that repository of good practice case studies, which we've already started to do, and to showcase that work across our system. We've got the benefit of such a large-scale ICS that we can share and spread good practice that may have been developed in one part of our system and apply it across the whole of the North East and North Cumbria. And then there's a final one there around our relationship with the philanthropic sector, which is an important area for us. Our local community foundations, of which we're fortunate to have some really strong community foundations in our patch, are very keen to work with us and connect philanthropic giving to interesting and emerging and innovative practice on the ground that we want to support as well. And then finally, given that our local delivery team structures are now settling in, some priorities for place-based working, which is usually the place where most of our joint working takes place, understandably, with the VCSE sector. So ensuring that appropriate VCSE involvement in our emerging place-based governance arrangements, but also to consider that balance of funding issue, between VCSE infrastructure and direct service delivery. And then in terms of that investment into service delivery, to look at how we can increase the value and percentage of local commissioning on VCSE services, ensuring full cost recovery wherever we can, and the percentage of VCSE contracts that are longer than 12 months in duration, which can, we think, help to sustain the sustainability of the sector, but also to look at things like the effectiveness of our local social prescribing initiatives, again, led at place, but an increasingly important part of the landscape of services, with our primary care colleagues, and how that can make a difference on tackling issues like economic inactivity, which we've already touched on this morning, which I think is going to be a really important agenda for us. So hopefully that was helpful, but I'm very happy to take questions.
Lisa.
Thank you. Firstly, I'd just like to welcome the content of the report. I think it's a massive shift from where we were 2 years ago, and the the willingness of the ICB to work with the partnership programme to look at some of the issues affecting the sector and think about systemic ways of working to address them is really positive. In terms of just a quick correction to the number, I think it's correct in the report, but Dan referred to 16,000 VCSE organisations. That was from a report 3 years ago, and it's now 11,000. Just to correct that. And I have a bit of feedback, if I may, from our North East Local Infrastructure Network, who wanted to share their thoughts on the report. They fully support the intention of the stock take and agree with most of the content, and appreciate the time and focus that was given to producing it, and the recognition of the value of the VCSE sector as a whole. They particularly welcome the suggestion of an increase in investment in the sector to 1% of the budget, and the inclusion of examples of successful working with local infrastructure in Durham and North Tyneside. They would like the board to recognise that since the stocktake was written, as has been previously mentioned by a number of you already, the sector is facing further significant financial challenges as a result of the recent budget. This figure is tens of millions a year, and whereas the Office for Budget Responsibility assumes companies will be able to meet some of these increased costs by raising prices or lowering profits, these are not options for the sector. A third option of lower wages is also not viable, given that salaries are already lower in the sector than elsewhere. So without any support for the sector, this will mean reduced activity at a time when the ICB is looking to increase the use of the sector for strategic reasons, when the sector is already facing considerable financial strain. We're encouraged to see that there's reference to lack of funding of the infrastructure role across the wider NHS. Local infrastructure organisations in most areas of the North East currently receive no funding for the liaison role between the sector and the NHS. Where there is funding shown in the appendix, they believe it's for mostly of delivery of separate projects. And there's a good model of local funding elsewhere in the system that could be built upon, and they would welcome the opportunity to work with the ICB to develop the thinking on this, as would the partnership programme. They would like to understand how any discussion on shifting the balance or focus of funding would happen and whereabouts this would happen. Everyone is keen to be part of the discussion and develop a future model of VCSE involvement that has greater depth in terms of local voice and supports the focus on primacy of place. A more general point that if we're ever to achieve a shift left, we need the ICB to reflect on how current evaluation processes could change to allow for longer-term preventative work in the VCSE to be funded. For example, for winter pressures, additional ambulance service funding will always take priority unless the evaluation or scoring on need changes to consider effect of longer-term prevention. And some of this can be picked up in the work that we're doing around the outcomes monitoring framework for Assura. Thank you.
Thank you. I'll ask Dan to comment when everyone's had their made their comments. Christopher Eckes-Belcher.
Thank you, Salim. It was really just about the strengthening the communication, because for all Health Watch works alongside the voluntary community sector, we're not part of the voluntary community sector. And when we are working with the voluntary community sector, in some of our places, there isn't a local infrastructure organisation. So it's really just that offer of help that, like, you know, from a Health Watch perspective, because we are working with those at place that don't have a lead infrastructure organisation, that if you want the communication to go out, then please call upon Health Watch, and we can do that through the Health Watch network.
Thank you very much. John Rush.
As you outlined at the start of the meeting, I'm probably sitting with a foot in both of these camps, actually, Salim. And a couple of points. Firstly, the report is very thoughtful and very considerate, and it really covers the main areas of points of view from an ICB perspective, from the points of view from the VCSE's perspective, and I get it, and I commend you, Dan, because I know you've probably spent most of the time doing that report, and I thought it was very thoughtful. Just a couple of key things for me, and I think it's difficult when you're a large organisation such as ourselves, and I mean a massive organisation. You always want to try and go to 1 point or 2 points of contact. You're not going to get that with the VCSE sector. It operates in a completely different way. So I know, whilst we have some big charitable organisations who provide fantastic services, we've got to have a way of integrating and working with them, the same as we've got to have a way of of working with very small charities in areas. I know you sort of alluded to Sacriston there as well, down in your report, but the ability to stretch into those as well and provide hands-on support to individuals in communities, however it's done, whether it's via a food bank, whether it's via someone's support, helping someone get back into employment that I mentioned before, is really valuable. So we've got to adapt not just to one of those approaches, we've got to do both. And I think that probably is one of the main bits I would get from that. The other bits as well, I think that you've touched on it already in the R-Party recommendations. Whenever we as a large organisation interact with other organisations, we sometimes hold them to like this contractual arrangement. That's really difficult for some small organisations to be able to achieve that. And I know you've alluded to that as one of your recommendations, that it's got to be proportionate. And I think that is a very interesting and a very valuable point as well. I recommend, should we say, fully support the points you've made about full cost recovery, and particularly in relation to longer term funding. I mean, I came from a meeting a few weeks ago within Cumbria, and they're talking one of their key aims is to try and get 2-3 year funding to get a little bit of stability in being able to provide those projects. And I just, as I say, I reiterate that it's the final point that if we're going to create, you know, people like Lisa sitting around the table and how that comes about, I think that's got to be done via the VCSE sector, and that's their nominees. Because if we appoint and say, oh, we want that person, then that's not going to work as well. So I think it's really clear is that if anyone who's sat around the table it's come from the sector, however they design it, to be that person sitting around that table either locally or regionally, as we would be for an ICB. So they're my only points. Well, thank you.
Well, thank you very much. Excuse me. Thank you very much, and very valuable contribution to the discussion, noting from our earlier declaration of interest that John and Lisa can't take part in the decision on this report. Dan, do you want to comment on any of the things that have been said there? A lot of them were clarifying and setting other context.
It's a really interesting one about the points of contact. We're continuing to support the VCSE partnership programme approach and encourage linkages at place through local infrastructure organisations and others, and through the general course of our work with the voluntary sector more broadly, because you can't just do it through one single channel, given the scale and diversity of the sector. We're also conscious that we put our VCSE partnership programme arrangements in pretty early, actually, in the development of our ICB, before our local delivery team arrangements were established. They are now established and bedding in, so we thought there was a great opportunity to revisit the local relationships with the sector as well, and that's why we covered that in the paper. And very grateful to Christopher's support as well in terms of the reach of Health Watch, in terms of another point of engagement.
Yep. Okay, thank you. There doesn't seem to be any more comments. Are people happy to endorse the recommendations of the report? Good. Well, thank you very much indeed. Well, it's a lot of business we've covered this morning. We're now breaking for lunch, and we'll resume at 1:05. Well, welcome back, everybody. This is resuming the board meeting in North East and North Cumbria Integrated Care Board for 26th of November 2024. And we're moving on now to a couple of areas where we're taking a particular focus. First of all, the strategy for involving people and communities, covering the period 2024 to 2028. And Claire Riley would have been presenting this, but Dan Jackson is deputising for today and is going to present it.
Thank you, Chair. And yes, thanks for the invitation to cover off our revised and refreshed Involving People and Communities strategy 2024 to 28. We first developed an involvement strategy right at the very start of our existence as an ICB, and we're pleased to have spent some more time updating this document in partnership with our colleagues at Healthwatch, who've done some really important engagement work on this document itself, and we think it's really helped to produce a really valuable piece of work. So obviously, when it comes to our role as an ICB and why we need to involve the communities we're here to serve, that's obvious. That's obvious almost, isn't it? You know, we're here to work with our communities, not to do things to them. So we need to understand what their priorities are. It's absolutely essential in planning and service delivery. Almost goes without saying. And as an ICB, we do have a legal duty to involve. You know, in terms of major service change and so on, there are formal processes that we need to undertake. But we also want to play a role in empowering local communities to take ownership of the health and well-being agenda, and also to understand what's important to those communities so that we can commission the services that meet those needs. And I'll go on to talk about how we're using a broad range of sources of insight to inform the prioritisation we do as an integrated care board. And people regularly tell us that they do want to be involved in ways that help to bring about change, and how important that is to improving the services that they access. In terms of developing this updated strategy, I mentioned that we've involved Healthwatch to help us with this, and they've done some really useful work in engaging with local service users and communities around what's important to them as we refreshed this strategy. And as a direct result of that, that helped us to simplify the document itself and also to clarify the principles we're working to. And you'll see we've got the three there of meaningful involvement, removing barriers to engagement and involvement, and then listening to feedback and acting on what we hear. And I'll come on to give some examples of the difference that has made. And basic things like using plain English, which I think is always a useful discipline to apply. And we've done some interesting work in a range of fields around health literacy, and we want to apply that same thinking to documents like this, so they're as easy to read and understand as possible. I must say as well that, as well as this document that sets out our strategic aims, we do have a more detailed work plan that's still in development, but we're keen to share with you as soon as that's completed. And it will be, all of those documents will be made available to the public on our website that sets out exactly the sort of actions we are taking to address the how question of how we do engagement as an ICB. So in terms of how we will work then, we do have a range of different methodologies that we use to reach people, whether that's online surveys or face-to-face engagement work, focus groups and so on. And that depends on the issue at hand and who we're trying to reach and how and what barriers they may face to participation in involvement and engagement activity. And we also work very closely with our partners in Healthwatch, obviously. The voluntary and community sector is another key source of community feedback, and local authorities and foundation trusts, for that matter, who also have important involvement and engagement duties. And in that work plan that I referred to, we set out, the range of tools that we will make use of, including new online survey tools, how we compile patient stories and how we embed that in all of our meetings. You heard Sir Pally talk before about how we heard patient stories at our most recent Quality and Safety Committee, for example, and that's really important to ground our work in that kind of the lived experience and finding out about that as often as possible. And then how we're developing things like involvement toolkits for our locality teams, but also our GP partners as well, who might be leading specific local work in their communities as well. So just to finish really on how the ICB is listening, I think it's important to demonstrate that we do value the voice of patients and understand what matters to them. And as part of that, we've established the Patient Voice Group, which is a subgroup, if that's the technical language, Deb, you correct me if I'm wrong, of the Quality and Safety Committee, so that we have a place where we can triangulate all of the various sources of service user and stakeholder feedback that we capture regularly through our involvement and engagement activity, but also through complaints data, for example, that we've already mentioned this morning, feedback from members of Parliament. We've Since the ICB was established, we've processed over 1,200 MP inquiries, and they're often a really useful source of patient insight, actually, because they often, members of the public obviously write to their members of parliament about issues they're concerned about, and we're able to use those insights to identify emerging issues. So, for example, recently we've had quite a flurry of correspondence around shared care agreements, for example, and the complexities around those issues. So we've worked with clinical colleagues to try and clarify that issue so that we can develop some standard communications materials on issues like that, or waiting lists for particular services, for example, that we can then look to address. So we now have that patient voice group that is the one place where we can do that triangulation, identify emerging trends and themes that need to be addressed, and that is reported formally back to through the Quality and Safety Committee, so that we understand what those themes are telling us. But just in terms of how our involvement and engagement activity is making a difference, I asked the team to compile a document, which probably is worth circulating, actually, with the minutes as for some examples of how listening has influenced the work of the ICB. And obviously, the listening work that Healthwatch undertook in terms of the refresh of this document is one example. But other strategic work I'd point to includes the work we did in partnership with Gateshead Health Foundation Trust on our women's health strategy, and where we engaged over 1,000 women to tell us what was working, what wasn't working for them, and that's helped to identify some key priorities in that space. You know, in everything from providing local women's health services at more convenient times, shorter waiting times in gynaecology, standardised menopause information, and that's come about as a direct result of the patient and service user feedback that we undertook. So there's some strategic examples, but then there's some very specific place-based activity that our teams have undertaken. So there was some work we did on school-age immunisation, and again that gave some practical insights into what were the best times and venues for those sorts of services to be delivered in, what information was important to parents on that programme, or hyper-local issues around proposed changes to GP services, for example, where the team worked closely with the GP practice involved and helped them to engage their community on those sorts of changes. So real practical issues where involvement and engagement really makes a difference. So this strategy has already been to Quality and Safety Committee, and it was approved to go forward to seek the board's recommendation, but very happy to take any further feedback and questions, Chair.
Thank you very much. I've been saying for some time that everyone should go back and look at the Act, which shows the Health and Care Act 2022, which shows the ICB has something like 12 or 13 statutory duties, and one of them is for involving people, patients and the public. And I thought it was nice the way this set out the way that we would be able to achieve that. But often when I talk to people around the country about the role of ICBs, they don't tie the work into those statutory duties. And I think it's incredibly important, because something that's a duty means you've got to account for it and talk about progress and decide how you're going to measure it and so on. So I like the way this was all set out against the duty that we have to do that. So thank you very much, Dan. Comments and questions then? Pally.
Thanks, Chair, and thank you for the report. I think this is a very important area, and when you're referring to the Quality and Safety Committee, as I said earlier, I think data, numbers and trends are important, but they don't necessarily give you an accurate picture of what matters to individual patients or groups of patients at ground level. If I may be bold enough to make this statement, I think we need to improve the mechanisms by which we hear what people are telling us and then act on them in a proper systemized manner. I don't think we're quite there yet. I think we're aware of many of the problems that we all face as patients, say, for example, access to dental services, but there is a whole myriad of other things that crop up, and we haven't necessarily formulated trains of thoughts or themes that we need to pursue in order to deal with those problems. At some stage, I feel that as an ICB, we need to take note of the main themes that are coming through, the softer intelligence main themes, and then formulate plans of action to deal with them. But this could be a hard thing because that might mean influencing trusts to change their behavior or influencing providers in different settings to act differently. I think it's an area that we need to really embrace much more solidly. I can't see how we can improve quality and safety until we go down that particular route. We can't improve it merely by looking at data and trends. That's my personal view.
Levi Buckley.
Yeah, thanks, Dan. I think this is a great piece of work, and it's really nice to see using Health Watch and other organisations to help us take a bit of independent challenge to how we're doing this work, so I really welcome that. Just a couple of brief points. I think it fits neatly with some of the other items we've discussed today. So thinking back to the complaints report today, which also included compliments, so you can see how we can triangulate with what the people who use our services are telling us, and indeed even maybe with the integrated delivery report, which highlights areas where we're performing particularly well or areas we could improve. So it really helps us think, what do we want to engage people on? I suppose the only couple of things that stood out for me, it mentions the Child Health Network, which, as you know, has now moved to the Oversight Group. We need to just change the name, and you were at the last meeting last week, which was great to see, Dan. And I just think we can strengthen perhaps the offer there from the Know Our Issues, the Youth Board, who is a resource that we support in the ICBU. Just make sure we can activate them when we want children and young people's voices. And although the paper describes the local authority interface, I just wondered if we can maybe just give a little bit more thought to the role of parent carer forums, who again are really well embedded in our local authorities and give us some really good insight, particularly around children and young people's services and some of the mental health challenges. So I really welcome this, really want to work with you in how we embed this locally. Thank you.
John Rush.
Just in terms of governance and oversight, so I understand it, I take it the strategy sits with Claire as the executive lead. It mentions obviously doing an annual report. Is the annual report going to the Quality and Safety Committee, or is it coming here, or is it coming to both? And then just in terms of driving the action plan, where is that going to be done at in terms of a committee, I suppose, in our structure? That was
Can you clarify that, Dan?
I understand that it's going to both. It's going to QSE first and then to board. But we can also take the detailed work plan to the QSE as well for their comment and approval.
We can maybe flag that up with Claire as something that needs to be resolved quite quickly. Yeah.
Yes.
Yeah. Good.
Okay. Right.
Okay. Other comments? Oh, Jacqueline, sorry, you were obscured by the confusion.
Thank you, Chair. Just two comments, if I may. Thanks for the paper and for presenting it today, Dan. The first is just picking up on Pally's comment about where do we do that thematic review and pull it through and across. And it's just worth noting on the page 18 of the integrated delivery report, we have got the themes coming out of the Health Watch general engagement there. And I've just had a look at them. There are 7 themes specific to key healthcare matters, and we've discussed them all during the course of this morning's board meeting. So I think that's quite an interesting kind of connection through. And we do use that opportunity to cross fertilise between various aspects of the report. But perhaps another question is where in our governance structure are we, if you like, examining those themes and having it in scope. So I think it's a really, really good point, but I think it's helpful to know that we're already trying to pull that through. And the second point I just wanted to make is just sort of welcome the reference throughout the paper to the work that we're doing together with the Boost Learning and Improvement System. And I think we're making real progress there, and that's one of the mediums through which, as you observe in the paper, we will try and make that connection through from intelligence to action to improvement. So I think that's still a kind of developing connection, but one of the things that we're really working hard to do is ensure that where we engage or hold a big event that's topic specific, that from the beginning we've got our kind of pick up and implementation framework agreed and worked through, so we know which part of the ICB is going to pick up the output of those sorts of big engagement exercises and take forward the learning from them. So I just wanted to observe that as well, if I may. Thanks.
Anne Fox.
Yeah, thank you. And I think as we talked about earlier as well, we are starting to do that triangulation, and the quality team are working on the type of quality reports that will come to the Quality and Safety Committee, so that we can make sure that actually if we're hearing, it's the signals, isn't it? Signals from some concerns, either through engagement or complaints or incidents, are we actually making reference to them in our quality assurance reports that are coming through the work that we do with our provider organisations and the review of services? And I think that is the key work that Sarah Dronsfield is leading with the quality team at the moment. So although it's probably happening in an implied way, it'll be much more explicit as we go forward.
Thank you. Yes, go ahead.
Thank you. I just wanted to also add and say we're doing a review of the Quality and Safety Committee as the terms of reference and also the cycle of business, but feeding into that is the Patient Voice Subcommittee. So again, that's where the kind of more detailed granulation and the sort of triangulation, would come through and feed through to the QSC, and then obviously ultimately up to the board as needed. And also just to note that Sarah Dronsfield and I are working sort of quite jointly on this in terms of what we need to do from a quality assurance, but also a quality governance perspective to make sure that's feeding through and being all pulled together as well.
Lisa Taylor.
Thank you. Just a point of correction for the final version of the report. It refers to Vaughan as having a seat on the ICB and the Patient Voice Committee, but it's actually the VCSE Partnership Programme, which is the alliance that spans the entire geography of our integrated care service system, rather than Vaughan, who is just the North East Infrastructure Organisation. So if those changes were able to be made, that would be great. Thank you.
Thank you. I think I've made sure there's no flags. Oh, yeah. Eileen, go ahead. All the cups and bottles are confusing me, you see.
And tissues. It was a very welcome report, and I was very pleased to be chairing Quality and Safety when the Patient Voice initiative was introduced. And it was very clear that listening to patient experience and carers' experience could help us understand the difficulties people face accessing services, or some of the barriers they encounter when they are in our health and care services. What was less clear to me was how they were actively involved in shaping the solutions. And we talk a lot about transforming things. We have learning improvement communities. I know there are often experts by experience there. And I see the word co-production is written in the report, but what I just struggled a little bit to see was the how. People with lived experience will actively be part of helping to identify the solutions and driving the solutions through. And maybe that's a little way down the pipes, but that was my observation.
Sam.
Yeah, I wonder whether the examples that you've got down, it'd be worthwhile circulating those to members of the board. We could append it to the papers. And I think the reality is it's probably done in a number of different ways at the moment, Eileen, you know, whether it's through the local maternity network, whether it's through aspects of community practice, whether it's through our autism work and learning disability work. That I think there are probably multiple examples. What we're trying to do through the learning and improvement approach through Boost is almost sort of codify this into the standard way of working, so that we don't end up in scenarios whereby we've pursued solutions without the co-production piece, without the meaningful involvement and lived experience. But I think it's done in a variety of forms. But I think we've got lots of examples we can share. But I think once we've put everybody through the improvement training, we've got our first 50 staff going through that. We can share the learning through the various programmes. We'll have this more embedded. I think also ensuring that we resource this from an infrastructure perspective, and so that we're not tokenistic on it at all, that we also kind of reward people. I was very struck again through the national engagement work on NHS Change at the moment, that members of the public are being supported, you know, and reimbursed to attend those events, and just make sure we've got that infrastructure in place to support people to engage as well.
If I could just add 2 small points, there is a very strong community of public involvement leads in the region. I know Jen Koo is well linked into the Creating Connections network, and we are leading nationally on trying to think about how we remunerate people for their involvement, but also how they don't face adverse consequences of participating, which can affect some people who are materially challenged. And I think the other thing, we've had material go around a little bit about the communication strategy. We know we need to engage a lot with our public and actually have some quite challenging conversations with them. There's nothing that helps those conversations go forward well than actually feeding back. You said, we heard, we did together. And I think there is something about just making sure that although we might know the different mechanisms by which things are being done together, actually feeding back very specifically and pithily to public members about the things that have changed because of their contribution to our thinking would be helpful.
Just to add, my experience is that the part of the patient voice which is overlooked amongst all the other good things that have done is exposing staff and students to very granular experiences, when the reaction usually is, how could they have said that to the patient, or how could they have done that? And then somebody in a group discussion says, well, could you think of yourself as doing it? Those sorts of things get really embedded, the learning from having listened to a real life encounter between a patient. That tends hardly to happen. It certainly doesn't happen as much in medical education as it should, but when I've seen it used, particularly when the story is told themselves by the patient or the family member, it's really very, very impactful, I think. Okay, I think we've probably exhausted all of the comments now, and we'll move on with thanks to Dan and Claire for the work on the strategy to the healthcare associated infection item, which is going to be presented by Anne Fox, who's interim chief nurse.
Thank you, Chair. Well, you've got the report in the pack, but I thought I would pick out some key headlines from the report to share with the board. There's been an enormous amount of activity, I think, in the last 12 months, largely led by Chris Pearcey, one of our directors of nursing, who's the SRO, and he has been working very closely with our partners from our provider organisations, infection control teams, exec teams, and also Ewan and the meds optimisation team, because of that relationship in terms of antibiotic prescribing. So this slide, which you've got in the pack, shows really the whole trust performance and area comparisons from 23 to 24, and you will see that overall it's demonstrating an increase in incidence with the main healthcare associated infections that we monitor and report on a national basis. I'm mindful you can't see the numbers probably for MRSA, but just to say that this year to date we have 11 cases compared to 7 cases that we had last year. There used to be a national framework because every case of MRSA has to be investigated, and as you know, we've now moved to PSERF as our methodology for learning, so any MRSA cases are investigated under the PSERF framework. And this really reflects the national picture in terms of that increased incidence in infection rates. This one actually shows for E. coli, and again you will see that the total across trust and community cases has also increased since 2023. There's a small amount of variation between if there's been an increase or a decrease in the community, but overall the position is still a trend of increase. But I really did want to focus on C. diff, and you can see on here that this is split by hospital and community acquired, which is how we report them. And we've seen 4 of our trusts have an increase, with the exception being Northumbria and North Cumbria, they've seen an increase in community cases rather than in trust cases. But nationally, for the first quarter this year, we've actually seen an increase of 18% on average, reported by the UK Health Security Agency, with that direct link to issues nationally with antibiotic prescribing. And there was a recent letter issued from the from UCSA on the 18th of November, aligned actually with World Antimicrobial Awareness Week, which was last week. And it really just reinforced the strategic plans that are being recommended by UCSA to deal with the issues that we've got for CDI and in fact all HCIAs, which is really that renewed focus on infection prevention, control and management, and actually really going back to the fundamental standards that have served us well, to strengthen surveillance, to enhance public engagement and education, the development of an AMR workforce, improved antimicrobial stewardship and disposal, also considering health disparities and health inequalities. And clearly all of these things we are aware of, we've known for some time, but we seem to actually need a re-energised focus to have the impact that we would like to have. One of the issues in our patch that we have, which has garnered some national interest, is the issue of CPE that we've had, particularly at Darlington, and there had been an outbreak earlier on this year. And it's an issue that the Trust have been grappling with for some time, and it's largely linked to estates and the types of drainage and I feel like I'm going to be a plumbing expert, the type of drainage and the traps in the sinks. The estate, their ward environments are smaller, so the sinks are in closer proximity to the bed, so you can understand from a droplet perspective it's difficult to manage. There has been a lot of activity undertaken, but still there wasn't the impact, the full impact that we would have liked to have seen in terms of the reduction. So there was a single item quality summit held on the 15th of October this year, and that has really helped us to refresh and to review and refresh the action plans that you can see in the appendices. They are the new action plans that have informed our whole approach to infection prevention and control, as well as that specific focus for CPE. So we do have some NHSE oversight for this, and following the summit, the Trust specifically are expanding their IPC service from 5 to 7 days. They've improved and they are reinvigorating their leadership and actually reminding everyone of the importance of fundamental standards, and doing an internal campaign which is being launched for their staff and visitors. And also one of the wards have already been upgraded to try and help this issue of the proximity of the sinks to the bed areas, and that upgrade is planned for the other wards in their patch. And there was a lot of learning for the entire ICB that came out of that event, and that recognition that we do have some older estate, so we do need to consider those environmental factors when we are developing our action plans across the area for all providers. We also have that challenge because of the estate of sometimes insufficient isolation areas, particularly when we're in times of surge, particularly as we're coming into winter. That's a real risk balance of being able to accept additional patients into an area to manage flow at front of house, but also be able to balance the risk about what's sensible and possible dependent on the type of patients who are in those areas. And as we know, we've got much more complex patients with comorbidities, and we're sometimes having to move patients around to make sure that they are being cared for with staff with the right skill set, but that builds in an additional risk to the issues. There is no doubt that in terms of those fundamental standards, we have found areas where hand hygiene has not been what we expected to be, environmental cleanliness has not been what we expected to be, so there's been a real refocus on making sure that we are reminding everyone, from every person who walks into the hospital to the executive teams and boards, that it's everybody's business. And The national picture, as I said, actually reflects the same issues. But going back to what's most effective, the most effective tool we still have are those fundamental standards and really good hand hygiene for everyone. And there's lots of links to the antimicrobial prescribing issues. And in the letter that came out for Antimicrobial Resistance Week, it showed all of the rates across the country. So we are still at the top in terms of antibiotic prescribing. But when you look at the England average for the number of days, which is one of the strategies that we're trying to do to reduce antimicrobial resistance, we're actually below the England average in a positive way for that. So we are making some inroads. And we're probably about the top of the lower third quartile for CDI rates when we compare nationally. So although we've seen an increase where we are in the national picture, we've still got work to do. But certainly like I say, we're at probably the top of the lower third quartile. So in terms of what action we are doing, we've updated the improvement plans across the whole system. We have weekly reporting and weekly engagement because, as I've said, the providers and their infection control teams, their exec teams and the boards are really engaged with the improvement activity that we're undertaking. And we've recently instigated how we can get that flow of information around decision making, particularly when people are making decisions about flow, particularly with some of the system pressures that we have, and to ensure that we've got that infection control voice in that clinical decision making in our provider organisations. Definitely reinforcing those fundamental standards. And in terms of the CPE activity, we had some support from the new hospital wards team and also from Leeds Trust, who'd had similar issues with CPE and had undertaken some specific actions. So that learning from elsewhere has also reinforced the content of our plans. And because there is so much activity and we've got work to do, we had a review of the activities of the Quality and Safety Committee in the cycle of business, and we are going to have some single item agenda sessions in addition to the usual cycle, and we've agreed that infection prevention and control and indeed the monitoring of the progress and some further details so we can have a full discussion and debate will come to a meeting in early 2025.
Okay, thank you very much, Anne. Comments and questions? David Chandler.
Well, I didn't think I was the fastest on the button there. Thank you, Chair. Anne, really helpful report. I'm not a clinician, as you know. I don't profess to be, but I'm just wondering about hand washing. So I read in the report about staff not being observed to commit to the 20-second rule, and I understand the importance of the 20-second rule. But I'm just wondering, do you think is there more to do in that regard around staff and visitors? And I feel like 10 years ago, it was really in your face. You couldn't get onto a ward without washing your hands, etc. And from recent visits to relatives and the like, it doesn't feel quite the same. So I'm just wondering, do you think we need to do more from a staff and relatives point of view in terms of hand hygiene?
More accurate would be hand hygiene, really, wouldn't it? Because the alcohol gels are a big part of this.
Yeah, absolutely. And that's why, really, as a result of this, everyone's reinvigorating their plans and their comms. And I know certainly from County Durham and Darlington, they're doing things that are really in your face as you walk into hospitals and departments. Because we were all so vigilant during COVID. I think everyone was hyper vigilant and we've forgotten. And we need to be reminded just how important really good hand hygiene is, and also environmental cleanliness as well. So it's really back to the basics, as well as some of the more pragmatic estates things that we need to do.
Thank you. Yes, Levi's next. Thank you.
Yeah, thank you, Anne. Please pass our thanks to Chris for the work into this report. I mean, as someone who's just finished a period of on-call, I can testify to the impact, not just for patients and their recovery, but also on capacity and the impact that then has on flow for the system. So not just for addressing avoidable infections, but for capacity. There are some real drivers here, aren't there? I welcome the action plans from the CPE Summit. I think that gives some good assurance about some of the learning and looking outside of the North East and Cumbria as well. I suppose in my mind when I was looking at this, I thought, absolutely, we've got a clear role in terms of oversight, developing communities of practice, sharing learning and putting challenge. But I suppose my plea is when it comes back to the Quality and Safety Committee, there is a real clear line of accountability for individual providers here. And I know, having a number of us worked to provider land, what you'd expect through IPC committees coming to board assurance. And I suppose I'd be interested in whether our Quality and Safety Committee felt the assurance statements from foundation trust boards is at the level we would want. And secondly, my final point, Anne, although the paper talks about giving us assurance against trajectories, unless I missed something, I don't think there were trajectories in the tables. So I think when it comes back, as you said, early 25, it probably needs to look at the trajectories. And I did wonder whether the rates of the different infections by provider should be done by bed days, so we can do maybe comparisons as well, because at the moment you can only compare year by year for the same provider, which is a good indicator of if there's been changes, but you can't do those comparisons across them, which may highlight, I don't know, one provider is doing some really good work we can learn. So welcome the report, just a few suggestions. Thank you.
Yeah, I can certainly look at the data to see whether we can do that. I'll ask Chris whether that's possible. I think assurance from providers, I think you're right, and we're, again, because we're developing our approach in terms of how we make sure we've got good assurance flows. But that for me would be one key thing, that because we're now integrated as members of the Trust Quality and Safety Committees, that's where we can make sure that we are informing and influencing the cycle of business and making sure we get that assurance flow through. So I'll definitely make sure that our colleagues are aware that that needs to be on there and that we get that flow of what the response has been to the output of the event. Yeah.
David Stout.
Yeah, just to, in fact, actually what Levi mentioned about patient days occurred to me as well, because some of those hospitals are much, much bigger than the other ones. Yeah. So that's, I mean, there shouldn't be any of it. So there should be zero tolerance, but nevertheless, if you are comparing against hospitals, then the size of the bars are misleading because of the size of activity, patient days. I suppose on the, looking at the absolute numbers, I mean, I can remember years ago when the numbers, this is a good thing, I think, when the numbers were much bigger than this. So I think from way back, when the emphasis started on this, we've made good progress, but then the point you're making is there was COVID and now it's turning back again. So now is the time to take a complete focus on it. I hesitate to mention this, but I'll say it, and it needs thinking through. I know from experience that when there were penalties, and I know there might be a groan on this, around substantial penalties, around exceeding targets on infection control, it wasn't half taken seriously through the whole organisation. And I just mention that because I can remember it. And, you know, it's back to all of this and all these things that you'd be doing, but it's hearts and minds. How do you ensure it gets done? Well, safety should be the reason, but perhaps that's just not enough. But if some of those penalties were massive. You know, your tolerance was like £1 million penalty that kicked in. And when that was communicated through the organisation, people took that really seriously. They didn't want to be responsible for losing £1 million. But anyway, I'll put that on the table anyway.
Essentially, you're absolutely right. It's probably one of the most evidence-based programs in healthcare. All you have to do is make sure that you follow to the letter the guidance, and you'll save lives. But not everybody does it, even with that potential gain.
Thank you, Chair. Thanks, Anne. That was really insightful. I was just wondering, Anne, what we're doing in terms of communication, because obviously as an ICB we have a big sphere of influence. I'm always on the lookout for, you know, public comms that are ongoing at this time of year. And we have a lot about vaccinations and being up to date with that. But I haven't really seen much about antimicrobial awareness or letting patients know that not every cough requires an antibiotic or every sore throat. So I think, you know, our patients are our biggest partners here, and I think, you know, the empowerment is really, really potent and empowering for us as well as a healthcare system. I was looking at the plan and I only saw one sentence in the framework which referenced really targeting patient work, so I just wonder whether we could kind of improve upon that.
Yeah, I can definitely pick that up with Chris and the comms team. I think it's how we fit it into those winter messages, isn't it? Is that part of that generic campaign?
Thank you. Just let Mike come in and then you can come in. So yes, go ahead.
So just touching on a similar point to David and start making reflections upon Levi's comments, so that the impact of this is significant from a financial perspective, in that every time you have a patient with a hospital-acquired infection, then that affects patient flow. That creates an order of downstream work trying to manage that patient flow because they're using beds that are limited. But also that then creates problems because of that poor patient flow then means there's more healthcare-acquired infections because patients are in corridors or in extra bays because they're not able to flow properly through the system. So ultimately, it's, as well as causing patient harm, it's causing significant financial costs to the ICB. And a lot of that, it sounds like from a flow perspective, is partly due to estates, in that we don't have the estates that are built to the standard or the size that are required by modern healthcare associated infection prevention standards. So I guess that's a long way around to the question, which is more towards Graham really, from an estate strategy of, are we factoring this into the business case for any new estates work that we do to try and make that more compelling, because it will ultimately have downstream benefits in terms of prevention of the costs related to healthcare infections.
Graham?
Yeah, thanks, Chairman. The short answer, Mike, is yes. We are, as colleagues will recall, we did bring the estate strategy. Many of the challenges linked to the age of our estate, etc. So ensuring that the estate is built to the appropriate standard is fundamental. But as I was just reading through the various action plans against each of these infection types, it goes back to my earlier comment about getting the basics right. You know, so if we, you know, there's a synergy with digital. If we get the hand hygiene, those basic things across each of those areas, it goes somewhere towards solving most of them. Not all, because there are some infection specifics, but estate is fundamental, and that's not going to be an overnight answer because we do need investment. But I think we can make some progress with just getting the basic essentials right and going back to that memory that we might have lost a little bit.
Yeah, I just wanted to pick up the point around the antibiotic resistance, because just yesterday, actually, we were promoting the messages around this, around kind of taking antibiotic resistance seriously and joining the movement, which is at seriouslyresistant.com. I think there's probably more we could do on this, and I think probably LinkedIn, maybe we should explore a North East North Cumbria wide campaign around infection prevention and control as well. We've done some very effective campaigns across the ICB, and I think probably what we need to do though is probably co-produce it with both people working in services and members of the public. Going back to our previous item, I think we've got a number of comms materials, but we probably need to co-produce it, because I think we need to get underneath some of the behaviours insights around kind of why we have gone, slipped slightly backwards on this, and what will be the nudges that will kind of get people to actually change their behaviour on this. And I think we need to involve the workforce as well as obviously patients and the community as well. So I think, it was a really helpful report, and why don't we take that away as an action?
Thank you. Eileen?
Well, I'm pleased to see this come to board, because when I was chairing quality and safety, I raised the issue that we had persistent difficulties in our dashboard to do with infections and infection control and hospital-acquired infections. As a behavioural scientist, I'm listening to the comments about penalties for poor personal behaviour. I can hear that one, but I'm really pleased the conversation's talked about estates. When this has been raised before, we also talked about the need for decant facilities. So sometimes you need to do, deep cleaning, and we have a difficulty not having sufficient decant facilities to be able to do that. So when you've got busy hospitals, a lot of pressure on patient flow, and then you don't have the ability to decant so you can do deep cleaning. So it's not all at the individual level. We have to look at this right across the hospital care system.
Thank you. Listening to this, I'm reminded of something in one of Hemingway's books. The sun also rises. The two characters, one has gone bankrupt, and the other character asks him, "Why did you go bankrupt?" And he answers in two ways: gradually and suddenly. And I think if you think about healthcare infection, there is a gradual, often a gradual loss of control. It slips. But if you were hit with a virus of pandemic potential, whether it's COVID or whether it's Ebola, hundreds of patients will die in a hospital. And in COVID, it was, I read recently a research paper showing that I think it was 10 million deaths worldwide as a result of poor infection prevention and control practices in health facilities. So if we ever got an Ebola virus in this country, in the state of our current level of control, we would be in a disaster area. So again, it's clear-cut what you need to do. There's no magic to it. Very evidence-based practices. And I would guess, in answer to David Chandler's question, if we were to look at levels of hand hygiene compliance, we would be below 50%. I'd be amazed if we weren't. And it should be up at 97, 98%. But it's a very good subject, I think, for us to major on in the next year in the quality area.
Definitely, thank you. We do have some areas, a lot of areas of really good compliance, but obviously those are point-in-time audits. It's about that sustainability of the practice that I think is absolutely key.
Okay, thank you. Now we're on to any questions that might have been submitted by members of the public.
No, just to confirm, we haven't received any questions, Chair.
Okay, so we don't have any other business. So just before I conclude, this is our last meeting before the Christmas break. So I'd like to thank particularly Sam and the executive team and the entire staff that are accountable to them for all the hard and excellent work they've done this year. It's really very much appreciated. I'd like to also thank the board members for all of their support and helping us to handle all the difficult subjects that have come up, and particularly the work of the committees, where a huge amount of time is spent on trying to make sure we get it right for when items come for decision or information or assurance to the board. So thank you, everybody, and I hope you all get a bit of a chance to relax over the holiday period. Meeting's concluded.